going over the care plan. I can go ahead and take something.
Yeah, what's your,
Come on. Good afternoon, everyone. We're going to go ahead and get started.
there you go.
There you go. Okay. Good afternoon, everyone. We're going to go ahead and get started. Thank you, everyone, for those of you in the room for being here again for the continuation of the care coordination meeting. Should we see who's on the phone since we have more people than usual on the phone?
Yes.
Patty, were you able to join in? Okay. Okay. We see. Who else is on the phone?
Warren Slavin.
Anyone else?
Yeah, this is John Chenapak.
Hi, John.
Hello.
Lori Doyle. I don't know if you can hear me.
We can hear you, Lori.
Thank you. And Adrian Ellis is with me as well. We're stuck in Annapolis.
Okay. Anyone else? Okay, today we're going to be, you have the agendas and the materials were sent to you beforehand, and today's focus is going to be on the care plans and elements of care planning. We spent some time going over care management and care coordination, and now to get into the details and the meat of what that looks like, and then hopefully back to the discussion that we had the last time, what should be done, coordinate at the state level, regional level, and at the hospital level. Before I turn it over to Carmela, I do want to say, since our last meeting, the HSCRC, in collaboration with the department, put out the regional collaborative RFP, and it's on our website, on HSCRC's website, and MHA's website. Was pushed out to multiple partners, and the goal of the RFP is for hospitals and community organizations to really come together to think about planning around care coordination and what that looks like for your respective community, and who are the important partners that need to be part of that decision-making process for care coordination, whether it happens or starts at the ambulatory provider or at the hospital, but what are all the pieces that need to come together for effective care coordination. So if you haven't seen the RFP yet, you should check out any one of our respective websites and take a look at that RFP. And with that, I will turn it over to Carmela.
Thank you, Laura. And the only thing that I would add, we will be in Jack's able hands, as always, today. We've got another dose of learning, as we said, compressed learning around care planning and on the ambulatory care side, but we also have some important discussion, and we hope beginning to get to some decision making today around some of the places where we can really highlight the accelerators and then make some investments. So with that, thank you.
Good, thank you. I want to welcome everybody, including our colleagues on the phone. We've got a busy agenda. We probably have 5 hours worth of work to do in 3 hours. So I'll do the best I can. We have some special guests appearing in the last hour, and I want to make sure we provide time for them. And so I'll be kind of a traffic cop and timekeeper today, but that's just in the interest to make sure that everyone who's taken time to be here gets a chance to talk. I just want to do a quick thank you. First, Matt Rowan, who's over there behind Dr. Haff. Matt has done yeoman work throughout this project and has synthesized all the homework assignments that many of you sent in into a document that we're going to go over today, and done many other things behind the scenes. Alice Burton, most of you know, provides the glue that holds this project together, and also a lot of the wisdom. So we couldn't do that without her. Kim Biascusi, where's Kim? Oh, there she is, who has just gotten everything out to everybody and kept us all moving in the right direction, and just done terrific work. And then my colleagues at HMA, Deb Gracie, Greg Vachon, and Art Jones. You heard from Deb at the last meeting, Greg in a moment, and Art also spoke at the last meeting. And they're all have made a wonderful contribution. My job is to show up on time, but there's a team behind me that's doing some tremendous work. Without any further ado, we're going to have some opening remarks. I encourage both speakers, and we've all talked about this, to keep their remarks brief. We have 20 minutes in total for the two of them. That's not enough, but I've mentioned to both of them to feel free to jump into the discussion afterwards. So I'm going to start with Dr. Greg Vachon at HMA, who's going to lead off, and he will be followed by Joanne Lynn.
And of those 20 minutes, I have less than 10%, much less, making it very brief. I'm Greg Vachon, principal at HMA. I'm a practicing physician on the south side of Chicago in internal medicine in FQHC, and I help a number of systems set up care coordination systems and execute on that. For today, just wanted to, you have some handouts on definitions. We'll use those definitions for today and maybe going forward. One point to make on those is that care coordination we're using as an umbrella term, as the whole thing. So care management, case management, all under the umbrella of care coordination. The second thing is, so you have those definitions, and care plans you have some examples of. So we have a definition of what a care plan is, and there's some examples as well. But do know that there is a wide variety of care plans in use and what people mean by it out there. So definitions you have. The other thing is risk, that we're going to be talking about high-risk populations. What you might do or what might be appropriate to do in a low-risk or very low-risk population could be very different. We're talking about the high-risk. And just context that Dr. Lynn, Joanne will be talking about one piece of the overall pie. So care coordination, a lot of things. One of them certainly the creation of the care plan and the care planning process. And with that, that's the
Thank you, Greg.
big important pie,
Well,
piece of the pie, which is high risk care planning.
Good, and I encourage you to jump in later and share your thoughts with us. Joanne.
Very glad to get to talk with you today. The care planning and care plans are sort of in flux and just being rediscovered and reworked. So it's not at all surprising that we are not entirely settled on exactly what we mean and exactly how to go about it. The advent of care plans as a serious element in medical care really reflects the transition from mostly being acute care and responsive to a person's medical crisis or situation to dealing with chronic illness, where the person is going to continue to have this condition well into the future. So, you know, a 42-year-old woman who comes in with a gallbladder attack, needed a gallbladder surgery in general and may have, a couple of weeks of getting over that, and that was it. That was the care plan pretty much. Now, the person who comes in with heart failure or COPD or strokes or dementia is going to be living with that and in general getting worse through to the end of life. So instead of the emphasis that I was taught when I was in medical school of emphasis on the history and the physical, the current state of the person, the emphasis now has to include what is this person's future. And that's the big shift, is what is this person's future, how are they going to live, how are they going to live with the strengths and weaknesses they bring to the table. And as we know, people come to the table with very different strengths and weaknesses and challenges. So you end up having to have an individualized care plan. So one of the major markers of shifting to chronic illness is the centering on an adequate care plan and figuring out how multiple parties can participate in generating it and can have it as a reference for their ongoing work. So it's in many ways a new element. It was a trivial element 30 years ago, and now it's become really quite central. So we're going to walk through just some very basic overview of care plans, at least as an ideal, and then point you to the examples. You really need a comprehensive understanding of the person's situation, not just their medical situation, which is often complicated enough, but also their living situation. What kind of housing do they have? Who's around to be helpful? What kind of financial resources do they have? Because this will help shape what's possible to do. And then that generates a person-centered, or I actually prefer person-driven care plan, where it's really the person's preferences and priorities that determine a lot about the trade-offs that are done. So what are the steps? First off, you have to know who really needs comprehensive care planning. So, the kid who fell out of the tree and has a straightforward fracture of their humerus doesn't need much of a care plan. They need their arm set. But the person who is living with multiple chronic conditions or with ongoing functional care needs from dementia or from illnesses or weaknesses or injuries, the person who is mentally disabled, either from a progressive illness like Alzheimer's or at birth with developmental delay and disability. ESRD patients are very complicated and a sizable group, so it's worth calling them out specifically. And then people who are coming to the end of their lives, where very often the priorities and trade-offs become different than they would have been 10 or 15 years earlier. So you have to think in terms of who you're going to target for comprehensive care planning. And then the care planning requires knowing the current patient-family situation, the likely future situation, being able to really understand sort of the pace of this illness, and are they really likely to have much more needs within the next few weeks or months, or to be stable for a long time, the kinds of things the person and their family need to have in order to really begin to make plans, and the relevant time frame for care planning. The person who's just had a stroke, the care plan might be 6 hours long. The person who is living with a stroke and has hemiplegia and speech difficulties, the plan might well be a 6-month plan. So you have to have an understanding of what the rhythm of the illness is to make a care plan that fits. And the patient and family priorities. People have very different priorities, especially as they come toward the end of life and live with complicated illness. This is probably the only thing you'll remember specifically from what I say. I've had 2 elderly gentlemen who wanted to make sure they were schnockered at the end of life. That's a technical term. So they didn't call out to Mabel while Maud was at the bedside. You'll remember that as why you have to live with the person's priorities. You have to have negotiation over the care plan, because ordinarily people want everything. I want to win the lottery and live in a mansion and have many people that have paid at good salaries and all sorts of wonderful things. And ordinarily we have to make trade-offs, and we're pretty used to those in our ordinary lives. But when we come up against trade-offs that are much more, in a sense, sort of deep cutting into our being, are we going to go for more comfort or more awakeness? We're going to go for something that costs a good deal, or we're going to try to preserve the family business. These are more difficult trade-offs, and has to be driven by what the person and their family really come to value. And then we have to have the care plan really available to those who need it 24/7. There has to be a way to layer it so that the Meals on Wheels sees what they have to see, and the cardiologist sees what they have to see, and the ER doc sees what they have to see. And maybe everybody can get to all the deep information, but you can't have all the deep information showing up at the first glance. The ER doc has to be able to know the basic situation pretty quickly, because they're never going to read 70 pages. So then we need evaluation and feedback. I have yet to see a care system that is doing this in a good way. Even PACE plans that have a long history of developing care plans very rarely evaluate them and provide feedback as to whether they're doing a really good job. But that's, of course, how systems learn. So we really need to start thinking in terms of how to understand whether we're doing a good job. And then there's this very interesting piece, which no one has quite capitalized on yet, which is that if we had decent care plans, and especially if they were annotated as to where we had to compromise the care planning because of availability or quality of services, you would have a remarkable tool for regional planning. So if you knew for Frederick County that there were 1,000 people who were needing care plans, and you had 950 of them, you could machine them pretty readily and see how many aides are needed in Frederick County, how many need to be able to deal with dementia, where are the hot spots, you could geomap things. Why are we compromising on care plans? Well, it's because we have a 3-month delay in Meals on Wheels. So thinking also of care plans once you have them really functioning as also a tool for regional planning, I think is a really forward-thinking possibility. The details on some of the care planning elements, the patient-family situation, obviously we need to know the medical situation, the disabilities, the things the person has to live with. And those often entail some compromises, as medications interact and treatment for one thing complicates another and that sort of thing. Then we need housing, food, and transportation. Those 3 are the 3 biggies in personal support. Then we need caregiving and personal care. The person needs spoon-fed 4 times a day needs someone to do the spoon feeding. So what are those sorts of needs and who's available for helping out? And then relationships, financing, and issues of abuse and neglect. That sort of rounds it out. What really matters to this person, and by relationships I include spiritual relationships. What is important to this person? How do they stay in touch with their humanity? What kind of resources can they bring to bear in terms of financing? And then there's the ongoing risk of neglect, especially in the elderly, and abuse at younger ages. We often forget that 10% of our families are afflicted with either domestic abuse or substance abuse, and kind of skim over this issue, but it's actually fairly common and needs to be brought to the fore more. And then I also highlighted the care plan. We need to really know what the person's goals are and to be able to say them in the patient or family's way of saying it. Is the goal to be able to be present at the granddaughter's wedding in June, or is the goal to be able to finish the great American novel, or whatever else? Some people just want to see the flowers bloom, but we need to be able to say the goals in their terms in order to know whether we meet them. And then the services need to be arrayed, and who is responsible for the various kinds of services that make it possible for this person to live meaningfully and comfortably despite their array of challenges. And we need, in general, an overall responsible party, someone who's going to be the go-to person for this person. That's usually the care coordinator. That could be the primary care physician. It could be a paid care coordinator. It could be the office nurse. But the patient and family need to know who is the go-to person. And that go-to person needs to know how to get in touch with all the other parties and get things done. The likely challenges and responses, this is what are the likely complications. So you don't really have a care plan for COPD without having a plan for the next time the person really gets in trouble and is very short of breath. The person who is drifting downhill with dementia, or what do you do when the person gets to the point where their behavioral issues are a real problem? If you have standby plans for the most common things to arise, or the most important ones, then there's very much less emergency because people already know what they're going to do. The time for a scheduled review, and as I said, that could be 6 hours from now or it could be 6 months from now. So we need to know if everything goes as expected, when are we going to revisit with one another whether this is really working. Obviously, that time for review could be moved up by the person having a calamity in the meantime. But it's surprising how often people actually go to the time of scheduled review. The care plan has to be available 24/7. Someone calls in the middle of the night, Mom seems to have a terrible stomach ache. I can't figure out what's going on. The person who is answering the phone has to be able to get to the care plan, has to know whether the person's already made decisions about things, whether they have an illness that's likely to cause this kind of thing, whether their medications might be causing it. You need to be able to respond very quickly, otherwise people are in the ER. So lots of these folks get most of their primary care in the emergency room unless they have a good system of care that's able to see them and tap into their care plan very quickly. You need to have the care plan available to the relevant service providers, and as I say, with a presentation layer that makes it possible for that person to see what they need to see. And then you need to know who the care team members are and to know how to reach them. That looks like it's going to be one of the few things that makes it into the Meaningful Use 3 requirements. But one of the important things is that the care team always includes the patient and caregivers. So it's not that the care team makes a care plan and then hands it to the patient, but the patient or the family, if the family is representing the patient, has to really be involved in the creation of the care plan. So the care plan is showing up in a whole bunch of ways. It's a core requirement and commitment of the PACE program, the program of all-inclusive care of the elderly. The home care now must generate a care plan, and hospice always has had to generate a care plan. Obviously, the hospice care plan tends to be rather brief. The PACE care plan tends to be rather comprehensive, but you can learn a lot from looking at the two. The new chronic care coordination code, the CCM code that Medicare has recently promulgated, it requires a care plan, requires the care plan to be available 24/7. This is one of the ways that some of our practitioners could begin to be able to pay for the services that they're providing. And then there's a thin version in Meaningful Use 3, but it only has to be adequate for either a referral or for just a couple of days. So it's really a reactive care plan, not really a longitudinal care plan that's required for that. The Chronic Care Management Code, just because it's new and offers some interesting possibilities, I'll tell you a little about it. This is the list of elements typically included in a care plan. This is CMS's list. They did not make this part of regulation. They just listed it as these are the things typically included. So there's still some elbow room to define these. So a problem list, expected outcome and prognosis. I think it was interesting that they put that into that. I applauded when I read it. The measurable treatment goals, what is it you hope to achieve, symptom management and planned intervention, including preventive care, community and social services, plan for care coordination with other providers, medication management, responsible individual for each intervention, and requirements for periodic review and revision. So you can see it's reasonably comprehensive. There's some things you'd like to put in and some things you'd like to define, but it's not a bad list, especially for CMS to be able to put it out. The system evaluation I just wanted to pause on for a moment because it's a new and sort of breakthrough idea. Once we get to the point where you have lots of care plans, either for an enrolled population or for a geographic population, you could really use this for feedback, make a self-correcting process and a learning organization way of building adequacy of care plans. Right off the bat, we would have a lot of feedback about inadequate prognosis because in general, we do not give patients or families honest insight as to what it is they face. So I think that would be pretty well corrected pretty quickly if 6 months downstream there were whole lots of feedback saying, no one ever told us just how badly my mother would need 24/7 care, or that she would need someone with her all the time. We were led to believe that therapy was somehow going to get her back to her previous state. And I think we would also learn a lot about the comprehensiveness. The social work services tend to focus on the housing, transportation, personal care, and the medical services tend to focus on therapies and so on, and everybody misses medications. The average discharge from a hospital still has 2 medication errors. So, we need to really think of this comprehensively. And then we need to use the care plans to manage the service supply and quality. So you can spot where care plans are having to be compromised because you've got a big wait for services. Yes, the person would like to be at home and community-based services, but there's an 8-month wait or a 2-year wait or whatever it is. So you could really start honing in on where there are deficiencies. And so I have listed a few things to start thinking about as to whether these are useful things to try to do. You may see some of these as, things to throw away quickly. You may want to build on some of them, and I may well have missed some, although I took many of these from your responses last time. So one is to develop or acquire a standardized and user-friendly care plan tool and the processes to use it, possibly for some of these subsets of patients. One tool might not really serve the frail elders and the ESRD population. You may need to have them modified a bit. A second is interoperability of the electronic records so that you really could transfer care plans. That is inhibited somewhat by the fact that the major electronic medical records now in the market don't even have a slot to hook the care plan to. But you could modify lots of local care plans to at least allow you to hook a Word document, give it a little bit of structure, and that would greatly ease the interoperability as things move around. You could also have a solution in the cloud and take these very sick people who are not a majority of your patients, they're a minority, but to have their care plans encrypted and lodged in the cloud with appropriate access protections. You could give patients and families their care plans. We have found this to be remarkably effective. Patients and families take their on-paper care plans everywhere they go, and they can read off. You can be on the phone and you can say, okay, on page 3, because it's structured, is your POLST or any advanced care plans you have. Please read to me what that says. Or you can say, I need to see your medication list, and you can read it off. More and more, the grandkids around, and they can take a picture of it and send it to you. So, the most low-tech intervention can work as a patch for a while until we can get, smoother systems up and running. We can create standards and infrastructure that would allow the CMM code to be more widely used. Maryland has a real challenge in lots and lots of small practices many of which have not even adopted a certified medical record yet. So if there were a way to bring many of those into the fold and allow them to do this billing, that might be a way to get more and more doctors able to spend the time, or doctors' offices, because most of this is actually not done by the doctor. The doctor's time usually can be billed on a different code, and this can be the staff making sure that everything's working right. We can develop and implement metrics to evaluate and improve care planning. We could start with just, is there a care plan? And does it have at least 3 elements that we think are terribly important? But then gradually increase what it is that you have to have in order to have a good care plan. The 7th one there is create regional shared savings and gain sharing programs among all the different parties that turn on the use of care plans. And then the 8th one is regional and local initiatives to monitor and manage regional and local system supply and performance. This ties into the RFP that's just gone out. That regions that really want to take a hand in coordinating their local system could start having a hand in the care planning and in using care plans to help monitor and manage their system. And then that leads to the 9th one, which is developing the methods to aggregate the care plans so that you really can do that. So that was my off-the-cuff list. And let's pause and take any questions or comments.
Thank you, and before we move on, I want to allow our guest to introduce herself. I'm sorry I didn't get a chance to do that, but I believe you're sitting in for Tori.
Yes, my name is Dr. Pat Zapp. I'm sitting in for Tori Bayless.
Great, thank you and welcome. And maybe just one quick question, but we're going to be weaving you in, Joanne, through the day. If there's any quick clarification, because we got a full hour of facilitated discussion, and I want to move on as quickly as possible. Joanne covered a lot of ground. If anybody has a clarification or something they want to ask.
And so while you're thinking on that, is we put together 3 examples of care plans. And the one that's longest and might look daunting is actually very straightforward because the first 2 documents exist. So it's the H&P in the hospital and the discharge summary in the hospital, and then a doctor's progress note in the office. And then the care plan is just 8 or 10 lines. So you might just look through that, and then the others are more structured to start showing you how you could start getting this into machinable versions.
Yeah. Oh, I'm sorry, Debbie.
I apologize because I'm one of the few non-clinicians around the table. What is the percentage of compliance with the care plan? Is it the exception when it's not followed? Because it makes sense if it's adhered to. So I'm just curious.
There's this widespread rumor that advanced care plans are routinely ignored, and that's not been proven in any data. If they're clear enough, they are really followed. Clear enough and available. I mean, it doesn't help if they're sitting in your lawyer's office. The following of care plans has only been looked at in very special contexts like PACE, where of course they're followed. Everybody's been involved in putting them together, and everybody knows why they're done in a certain way, and what compromises have been made. So yeah, they're followed very well. In having care plans in ordinary practice, I don't know of any study that's shown whether the ER doc is willing to comply. But, in my experience, if somebody has a care plan like the one that's in the longer document here in the first example, what ER doc is going to turn that down? They're of course going to pick up on it. They're going to be so grateful that someone has had a conversation and that they know right where to pick it up. Okay, so you talked to your doctor 2 weeks ago. You've had some further conversation. What's the decision now? We need to know very soon because your mother's really in a tough spot. ER doc's going to love starting there rather than starting with, oh my God, where are we?
Yeah, I asked obviously because if we're going to make a huge investment in this, we're assuming that they will be followed and they're doing what they need to do.
I'm going to take 3 comments and then we're going to move on. Rob, give me your first name again. I'm sorry.
Pat.
Pat. Rob, Pat, and Adrian on the phone has transmitted a comment to me, a question which I'll be sure to include, and then we're going to move on. Rob.
Hi, this is Rob Tone. I was just going to give one more example of where care plans are used, in particular for the Medicare population. In this country right now, I believe it's about 2.5 million Medicare beneficiaries, so not a small number. that are in Medicare Advantage special needs plans. And if you're in a special needs plan, by definition, you must be on a patient-centric, individual care plan. And if you look at the quality metrics and results of those care plans, the people on diabetes who their A1Cs have been brought down, the people who have been compliant with their medicines, the people who have gotten flu shots, the people who, you can go on and on and on with, there's about 55 quality measures that get scored. And I can tell you, it's not, when you say is a care plan followed, I don't know, it kind of makes me think, does my kid do everything I tell him to do? If you just do some of it, we're just, healthcare is not, healthcare is not perfect. So to me, the idea is to move in the right direction. And so if you establish a relationship with these beneficiaries and you educate them about their disease and teach them how to eat and teach them to take their medicine, if you get 70% of the way there, you've moved the needle a long way. But I think that the real point is that in Medicare Advantage special needs plans, there's about 2.5 million Medicare beneficiaries on these things, and my opinion is they're making a difference every day.
Great, thanks. Pat?
Potentially very powerful tool. However, I would just say that working in a health system where the emergency room docs, primary care docs, and specialists are all on the same EMR, it's often difficult to get folks to look at each other's notes. They won't sift through a lot of note float. I think that the power in this feature is if we can make it cogent and also to list people on a registry if they have a care plan, so we're aware as soon as we log into their chart, boom, this is one of these people. Click here, read 5 sentences. This is what you need to know about this patient right now. You can read more later, but here's what you need to know.
Note float, I like that.
One way to think about that, too, is that the care plan I would think of as not a separate document per se, but data elements that exist throughout the EMR that are brought together into a view that you can look at any time. And there's different pieces of that. And it becomes a place, if it's well designed, to, okay, let me look there first.
Could I follow up on that?
Sure.
That was exactly my question, which is this really a Word document tacked on to the end of the EHR, or is it elements that get pulled out? Could you say a little bit more, and is yours a view of how it could be? Is that how, Joanne, I think you're describing it more as an addendum to the electronic medical record. I think that would be really important. And then maybe the physicians in the room, Steve, I'm looking at you. So when we talked about whoever presented in the emergency department, aren't you probably going to look at the EHR first? And I just would appreciate your thoughts.
Yeah, I mean, the first question, is there something like that? Yes, working in a system that is, we're documenting in various places throughout the care management software, which then brings up a PDF. And anytime you want to stamp it and say, okay, I looked at it this moment, that is what the care plan was at that moment. But you're not documented inside of one document and going back there and then documenting things in other places. It brings it together. I will say that that's not very common, and if you have a complex patient, and easier to do on, okay, we have a population-wide care plan that we need to do. This is with children with special needs, so it's already a high-risk population. But amongst those, the ones that need a lot more text-heavy data elements, they're going to get those in there, but it's not going to be structured in the same way.
But it depends upon having an EMR that labels the elements about future in a way you can find them, which is not generally the case. So it isn't just a matter of pulling together a whole bunch of plans of care. Somebody has to make sense of them. And so the patient's goals are the things most missing from most records.
Okay, I have, oh, I'm sorry, Gary.
Yeah, and I would just say, one of the functions of the care plan is a summary of what's going on with that patient at the time. And there's good data elements there that are generally available and structured. There are medications that they've been on. If you have connections with the pharmacy, what's been filled, some of their, have they been adherent to those? So good summary information that informs, and it's not that future planning. You do need other elements, goals that in general are not well structured in the EMR to bring into a single document. In general, I would agree.
Good, thanks. I just want to read a question from Adrian Ellis, who's joined us by phone for Greg or Joanne or any of our experts, is the Medicare Care Coordination reimbursement available to dual eligibles? Okay, thank you. Okay, yes, please, Fozzie.
So I just want to answer the question of how do physicians and how do we use our electronic medical record to communicate that. And so in our electronic medical record, in the snapshot, which is the first page that everyone goes to, there's a problem list. And so one of the things is we've had to have everyone buy in to doing this. And so if someone has cancer, if someone has a chronic disease, the oncologist, every time they go in and they make a change, will copy and paste or just put the really important things of what are the next steps into that problem list. And so we have an agreement among all of us where to look. And so when our patients show up in, let's say, our urgent care, the urgent care physicians always know, they always look at the problem list. And then if they're there for something that has to do with their cancer, they open up that one area and then know exactly what the next steps are. So there are ways of doing it. I think we just have to agree on where people can look in a really quick way.
And how to share it across the system too, right? Yeah.
Okay, what I'd like to do now, thank you all. Thank you, Greg, Joanne. I'd like to turn your attention to two documents. First, the agenda and one specific part of it. And second, I hope you all have, you should have in your packet, it was sent in advance, but there's another copy today, a two-page attachment that says activity in a pink bar at the top. It's also on the screen. So we've got it in paper and electronic. And so let me start by pointing you to the bottom of the page under facilitated discussion, the 5 points. This is what I want to cover today, and not just cover, but try to drive towards some consensus. I want to start by saying this is based on your feedback, that several of you responded to Carmela's homework assignment and sent in your thoughts about the three most important things, activities that could be centered at the regional level, and three most important things that at the state level, maybe that state means statewide, it could also mean state government-led, different interpretations of that. And several of you did, and Matt synthesized that into this. And so let me just tick off quickly so you know, and then we'll move into discussion. What we want to accomplish is to have you review, you have reviewed, and comment on this chart. Does this look right to you? We've got X's where the state takes the lead, more at the regional level. What have we left off? In, what topics have we missed? I'm going to comment on that in a second. And so it's a markup session, but with the idea of ending the day with some consensus on targets of opportunity, where they would be, regional versus state, who takes the lead, what investments are needed to bring them to scale, and if we have time, may spill into the final meeting, how would they be financed? But particularly those questions, where, who takes the lead, what would it take, what's the role of CRISP, other agencies, so on. Yes, Rob.
For statewide, for clarification, I'm not
Hit
sure.
your microphone. For those on the
Just my own thought was it's not necessarily, just for point of clarification, is it who takes the lead or how do people organize themselves? In other words, if the hospital industry says this is more efficient if it's done on a statewide basis, I don't think the concept is that the state takes the lead. I think it's just the concept of how we organize ourselves to approach different components of care management.
And I wonder if I may take a stab at that. I'm exactly where you are, Rob. Maybe I can offer a friendly amendment. I think we'd be better off if that column were labeled state. That is, we're really looking to identify where's the locus of activity, control, and financing, in a sense, of that activity, as opposed to whether it should occur every place across the state. As an example, under engaged patients, item number 2 there, I would probably move into a regional slot. It doesn't mean it shouldn't happen statewide, but I think we're looking for things in the state column that are places where we're saying the state of Maryland, either in the guise of the HSCRC you know, the MHCC, the Department of Health and Mental Hygiene, and the Maryland Hospital Association, all of us together should be in the lead. You know, the notion of providing patient education, really important, but that can probably be done on a local basis, quite frankly, but we're saying this would be important for everybody to do. That would be my friendly amendment.
Okay, accepted.
I don't
Thank
know
you.
if anyone else did, though.
Well, no, that's fine. And I also want to mention, as we tee this up, that Steve Schenkel has offered several ideas of his own. We didn't quite get those in time to weave them into this matrix, but they're very good suggestions. So, Steve, I encourage you to add them to the list as we go through this discussion. Some very valuable ones. Okay.
I just actually did want to ask Carmela a question. So Rob brought in the concept that we might have private organization even if the state is involved in that process. So you mentioned just state agencies, but you didn't mean, other than MHA, but you didn't mean to preclude the idea that, for example, we think the CRISP organization is a successful organization of the private parties in the state. All of the health parties are sitting at the table, the hospitals, the physicians, and so that's a private organization, not-for-profit organization that has come together to make it happen. So it's not
helpful clarification.
Right, I just want to make sure that
exactly
we're talking
right.
about the same thing, and that people aren't thinking, oh wow, the 37 people at the HSCRC are going to execute care coordination.
No, and
just wanting to make sure that we pull back that expectation.
No, and in fact, and I'll share this later, when we come back to some of the data issues, I am increasingly of the view that we probably don't want to make a lot of this ourselves. We want to buy some of this.
Yeah.
But I think the impetus and the authority of the decision-making would be a group of, at the state level, we're saying as the state of Maryland key stakeholders, here's what we want to do. It doesn't mean we have to do it ourselves.
Yes. So, for example, like the HSCRC said, passed regulations that said you will submit your ADT data to CRISP, that we might be involved in a regulatory process to make sure that it works, but not that we're actually executing the nuts and bolts. So I just wanted to be real clear about that up front, that, about how it might be executed.
Well, that's an important point, and there are times when the state would need a vendor to do something that that vendor is deep in knowledge.
Private enterprise would need a vendor, not the state. So I want to keep coming back to that concept that we're not necessarily, CRISP hires its own vendors. The state isn't involved in that process of who CRISP hires. So we just want to keep coming back to that concept that we could be talking about private enterprise and private not-for-profit enterprise being involved in it, and not necessarily the state.
And maybe we think of state as small s, but that the idea would be there's an agreement that this should be a statewide, if you will, back to the statewide, state-led initiative. Doesn't have to be governmental.
Right.
I guess as I'm thinking about it.
The industry, but maybe broader than just hospitals, because CRISP is now more broader than just hospitals, and we're really trying to expand who we're thinking about when we think about the providers.
Okay, Greg, did you have a point?
I was just a suggestion of language, state level, maybe. So something might be done at the local level statewide, but state level is the level of the activity.
Okay, I think these, thank you, Greg. I think these all help some clarification. We have several categories here in the activity set. Before I go through them one by one, does anyone have an overall impression about this? If we might have missed something that you think is important that you'd like to see on the list, or about the whole allocation of state, however defined, and we've clarified that a lot. versus regional. Any impressions about this whole schematic before we get more specific? Yeah. Okay. Okay.
Question real quick.
Sure, Gene.
So is there, do we have any idea how we're going to do some of this stuff? And maybe it's too early, but having like a third little column might, just with a rough game plan, might not be a bad idea, and it might solve Carmela's point a little bit, because I think you make a good one. You know, how are we actually doing this, and who's going to do it is really the question. It's nice to know where it's going to be done, but
yeah,
even if it's an erasable section where we keep changing it depending on what we decide.
Good point. Maybe an implementation strategy, something like that, a third column. Yeah. Yeah. Point well taken. Okay. Yes, Debbie.
The one thing I didn't see real clearly here, and maybe it's embedded, is the discussion we had about the linkage of the various settings. I mean, we talk about interoperability here, but we had talked specifically about mental health and skilled nursing, and I think that that really offers a lot of opportunity if we can make sure that we're connecting.
Yeah, good point. I think that was one of the things on Steve's list. If you want, I don't want to, but one of Steve's point was a regional approach to nursing and hospice transfers, but he also had a point on mental health. It's your point 3, Steve. Integration of mental health with the rest of the model, including central referral, support of after-hours psychiatry and social work, access to drug treatment, and inclusion of records in CRISP and other shared resources. That begins to get at your point, and some of the points Joanne was making of bringing together the behavioral health integration, achieving that, bringing together the social services, the handoffs across sites of care.
Okay. You're talking maybe even about more fundamental of just getting people connected too. I think Steve has. I think you have that on your list too, of just making sure that people that the different parties are actually getting connected to a common hub, the CRISP, to share the information. So the long-term, getting people connected as a priority at a state level.
And in terms of implementation, that may be one of those things for the last column, and where HSCRC can have an influence. I'm thinking particularly psychiatric care, where there are completely different sets of rules around the protection of information. So how to do that can be fairly challenging and may in fact take legislative or other regulatory effort. It's sort of something that HSCRC could ease the way toward that change.
One overarching thought that I had, and I'm struggling still with the table, some of the things on the table are very specific. A couple of my own, for example, in this behavioral health conversation, my thought was piloting behavioral health care coordination models. I know Lori Doyle's on the phone. She may have some thoughts or suggestions, but some are very specific and some are very general. And I think one of the things we may have to wrestle with a little bit today is providing some more detail to some of the suggestions here that are more general, so we can get to Jean's last column to understand what the implementation strategy would be. So some are easier to understand, efforts to standardize, for example. Others, for example, providing patient education. I think we need to talk more about that so we know where to take it next.
Yeah, that's a good point. There's kind of apples and oranges with regard to the specificity. Any other general comments? Okay. I thought maybe we would start with the first activity level, identifying individuals with complex needs and stratifications. I know, Rob, this is something you've thought about a lot and worked on quite heavily, particularly in the Medicare population, and there is, I think, a consensus in this group and around starting with high needs Medicare patients and trying to meet their needs. Any thoughts that come to your mind about, I know you've actually been doing this, about best practices, where it makes sense to organize them, and how to get it done in a practical sense?
Just that this is a really good example of one that makes sense for us to all do together. That why not get one data set and do the analysis together? If we can get, I think we've talked about trying to get 2 years of claims history from Medicare. I think that would be very helpful. I mean, obviously there's lots of places where you have hospital data. I mean, we have hospital data and hospital outpatient data, but the ambulatory data adds a very big layer to the predictability. So it would be really good if we could get 2 years of claims history. And then there's all sorts of vendors out there that can help you build the model once you have that. I think it's very good to start with the Medicare HCC system, recreate that, and then you can overlay.
I want to say a word about.
I'm sorry?
You want to explain that? I mean,
Sure.
I know what it is, but
it's called the Hierarchical Clinical Condition System. It's every year the federal government runs every single Medicare beneficiary in this country through a risk model and assigns them a risk score. It's a good place to start, and then there's organizations that have software that you overlay on that even takes that to the next level. And so there would be very good ways to start with the data and identify, pick your number, 20% of the 800,000 Medicare beneficiaries in there, 15, 20, 25, some number that are the more high-risk beneficiaries. And it would be, and then I think we should, as I understand it, ACOs get monthly updates of data. So I think we're like a big ACO. We're at risk for volume. So the same way ACOs get monthly updates, we should get monthly updates. And then we can, and again, then it continues to make sense to have that in a central place like at CRIS, using external vendors that could help us stratify that population.
Good. Thank you. And by the way, as we go, I think I saw David here from CRIS. Oh, yeah, there you are. Anytime you want to jump in, David, during the afternoon, please do, because CRIS will be referred to again and again, and so we welcome your thoughts anytime. Yes, please.
And I wonder if I could share a little bit of thinking. I wonder if we don't add a couple of pieces under number 1 here.
Okay.
Between our last meeting, I had the chance with some of my colleagues at MHA to visit with the folks at Optum and to take a look at some of the data analytic capability that they have. And it was one of those, sort of between the eyes experience. And it was to some of what I think I saw Amy in the audience. Amy was sharing with us from the experience at Johns Hopkins. Just the data warehousing aspect of this and data cleaning aspect of what we're talking about is really, really, really hard. And so one of the things I came out of that experience, sort of looking at what they're doing for their clients, is how do we make certain we're not thinking too small? How do we make certain that we are really building what we need to do what we hope to do? One thought I had is, do we add a letter C under number 1? So if A, as we talked about last time, is all about using existing data, and sorry, David, Chris coming in here, using existing data and connecting what we have. The second step is let's ask for the data. What's wrong in asking? CMS can say no, but we can do our best to ask. And then it's, okay, now what if we actually are the dog who catches the bumper? What if they say yes? And we get this massive amount of data. Is step C to really think about a data warehouse where we can store, clean, and normalize the data, and where we have the opportunity to begin to connect data beyond just the Medicare data. So data from the electronic medical record or other places, that's still a future conversation for us in terms of the how you do that. I'm going to guess it's probably not the HSCRC or the MHA, but here's where you could look at whether that's CRIS or other vendors. But I think we're really talking about a third step in here, which is if we get the data, there's a lot of work we have to do with that data to make it successful. And then you really get to that fourth step, which is the identifying the high-risk patients. So if we talk about parallel tracks, there's what can we do with our existing data, and some of the things, Rob, you've just mentioned to identify high-risk patients. But if we're going to ask for the data and try to build a warehouse, then there are all kinds of nifty software you can lay on top of that data once it's available. So I might suggest adding a C, which then gets you to the ability to identify patients in new and different ways.
So a C and D, really.
Yeah.
And what about, thank you, and what about an E? I don't mean to be getting ahead of myself, but feeding into later parts of this activities list, using that information in the process of forming care plans. Once you've identified these people, then isn't the next step, I'm looking at Rob because we've had this discussion before, I think, and that's easier said than done, but it seems now we have a 5-point flow. And
it becomes the registry patches.
Yeah. And I'd be open to anybody telling me what to think about how that might be done, where it might be done. These things involve investments of time and expertise and so on. Joanne.
As an interim, again, on the way to perfection, most of the patients are very easy to identify in the hospital. It is much more challenging to identify a person who is just becoming at high risk while they're not yet in the hospital. If you've got a very good electronic record and a lot of people feeding into it, you've got a real leg up. But if you've got people being seen in 6 different settings, the fact that the person's had a stroke but hasn't been hospitalized for it is really hard to find in real time. Yeah. But in the hospital, you can find almost everybody with very high reliability with none of these data systems.
But I think we can find the high-risk patients. The issue is if we find it in the hospital data, we have no idea who's taking care of them in the community. And so that data is really extremely useful to find out who's actually taking care of the patient. And you would be surprised how many ER visits we get in the hospital that don't record that the person's diabetic when they have acute diabetes, and it's not on the ER record because there's only one little piece of information on the ER record. So hopefully you would actually find that in some of that other data that you're getting for the patient. So I think there's just an incredible amount. We can really do a great job of identifying high-risk patients from the hospital records, and we should start with that. But there's an amazing layer of information that can be put to use out of that other data.
I think you just said it the way I was trying to, that we can get started with the stuff we've had at hand.
Absolutely.
While building.
Absolutely. So,
and then you can also use data to test whether you've actually found all the right people.
Absolutely. Absolutely. So, yes. Exactly. So, and I think we weren't skipping. We were kind of skipping A because everybody agrees on A already. Is that kind of true or
that's
not?
my impression. But if you don't, if there's any concern about that, or we've developed a flow here, but only among a few of us. So if anybody else wants to jump in or say I don't quite see it that way, or please do. And I think it's Amy back there, right? Amy, I do see you. Please join in, and thank you for your note, by the way, that you sent in. It was so helpful. We'll get you a mic, Amy.
And I apologize. I'm a little confused, and maybe it's just me, about, and I stepped in late, so again, I apologize. But where is the patient agreeing to have their health information shared across the state, and how are we, so as hospitals, we have an ethical challenge as well as a responsibility for care coordination. So much of what we are currently doing with payers who own patient information and our own patients and providers, and our strategies are to do all of these things and to share care plans across, but with patient understanding, with their permission. And so I am concerned as we talk about identifying high-risk patients and ensuring they have this and that.
where is the patient understanding who's got their health information and whether or not they want everybody in the state to have their health information and be making decisions on, quote, their behalf. I think this is very concerning, and I think I'm not sure that there's really been necessarily a survey that is rigorous enough at this point to find out what collaboratives are currently doing across the state from the hospital and the community that fits along these guidelines of what you're proposing. I'm just a little worried about, I'm not quite sure how this fits in. We're going to have this unbelievable care plan and we're going to attribute it to patients and providers, and the patient maybe knows they have it or not. I mean, it's a little different than if you're in a Medicare Advantage plan and you've signed up for it and you have a case manager or whatever and you know where your health information is. But this scares me a little bit.
There's a separate document, Amy, that goes through, and already in the data acquisition strategy, if you will, that lays out all of the issues that you just talked about, and that we need to develop policies and procedures and approaches of how data will be shared in an appropriate way. So that this isn't to say, hey, we're going to share data across everybody. That's actually laid out in very good detail in a separate document that was sent out to the work group. So this isn't we're not trying to get into the weeds of that, but that's a good example of what could be laid out at a state policy level, developed statewide, what's the approach, and how are we going to execute on making sure that we follow an approach that's appropriate.
Right.
But we don't have to solve that.
My only point, though, is maybe are we putting the cart before the horse as we're talking about strategies that are based on the use of that data to identify high-risk patients. That's my only point here. So because all of these things are important, but they are based on analysis of data, and that's
okay. Rob, thank you.
So, hi. So before, Jack, when you had asked about the predictive modeling and doing that together, I stopped at that point with the identification of the 20% of the 800,000, the 160,000 people, because I thought we were just talking about that piece. And this addresses Amy's point, too. The idea is that once you identify the high-risk people, and I welcome comments from the clinicians, the idea is now you've identified the people on whom you want to do health risk assessments. Because you can't develop a care plan just from claims data. You got to go do a HRA. It's self-goals. It's caregiver contact information, language preferences. It's all these things. So you got to go meet with the patient. So the whole point of the data exercise is just so that we don't have to do HRAs on 800,000 people. The idea is to get yourself from 800,000 people to 100,000 people, and then when you go do the HRAs on the 100,000 people that are going to allow you to generate the care plans, I'd like to think you could have a discussion with the person that says, hey, I'm here to be helpful with you. We're going to use this data to generate a care plan and be really helpful. And hey, by the way, do you mind if we share it? I mean, there have been many Medicare fee-for-service demos where it's exactly this. The federal government gives an organization data. The organization then reaches out, develops contact with the patient, develops a care plan, and then it gets shared. But the patients, I would think, I'm just thinking off the top of my head, that the patients opt in at the point where you go out and do the HRA and present yourself as someone that's just here to be useful for free.
Or in the CCM world, when they're signed up with the doctor's office to have their care plan done and shared.
Yeah, but the real point of the data is really to make it so that you don't have to do HRAs on 800,000 people, so that you can narrow the field and have a place to start.
Yeah, thank you. And in this document that Donna was referring to that was sent out, it's called Patient-Level Data to Support a Collaborative Care Coordination Initiative. At the end it said the plan must include, it lists 6 things, and the first one is patient protections and data security to ensure protection and appropriate use of health information. It's an important point, Amy, and point well taken.
Yes,
Mark.
just a clarifying point. touches on what Amy talked about. It touches on CRISP governance as well. And that is that CRISP was designed as a federated system where the providers who allow the data to be viewed actually still control the data. Other than PDMP, we do not have a model where clinical data is stored centrally by a non-provider entity as it's currently configured. So a data warehouse that would take in claims data and then marry that to clinical data is not something that I think we have any approval for, having been through all of this privacy and security meetings when we were setting CRISP up. I'm not sure that the resident community in Maryland is going to be totally comfortable with that. So I think we have, and so you sort of lost me on C, D, and E, right? So.
Maybe I can jump in since C was my silly idea. And that is, my thinking at the moment is just to remain entity agnostic. The place where, in my own head, I'm pretty sure is CRISP's role with the existing stuff. And then we're really moving into the what-if world. What if we get Medicare data, and what if we can get through the patient privacy issues, and what if we could start pulling EMR data, it's sort of out of the back of electronic medical records. And I don't know that we know what entity that may be, but I hear you loud and clear.
Yeah, and I think that if we have a second consent process, I think that will alleviate a lot of those concerns.
Good. Thank you. Yes, Howard.
Yeah. It's been mentioned once or twice already, this new issue of chronic care management codes that CMS has devised and became part of the fabric beginning in January of this year. And I don't think it's trivial. I think it's really a significant piece of probably the problem solving for what we're talking about now, because it does have embedded in it very clearly the requirement for the individual to consent to care management. So anyone who would be engaged in that process would give consent, and also consent to allow their information to be shared among all of the people in the care plan. And that's really at the ground level. That's at the provider level. The first things that we're talking about here, which are the CMS data, the global world, the things that have to do with high-level analytics and data warehouses are really important, but I don't think they're the priority. There are things that it will take us at least a long time to think about what the right way to do them, and probably longer than that to execute in a realistic way. It's taken large companies now decades to begin to make those kinds of data analytics and predictive modeling really useful at ground level. So I think it's a great idea, but I think leveraging exactly what we have now, what we have on the table, what we have around the table here, is a lot of very useful parts, CRISP not being the least of which, and our already existing several years of ENS data, and I don't put David on the spot here, but I think that the data analytics around that, without having to do a lot of heavy lift, will provide information to those who need it at the ground level that may be immediately useful, without having to wait for all of the other things and invest in all of the other things that we'll have to do someplace down the road.
Great. Okay. There's one thing I need to do here, because I'm mindful of the clock, and I want to come to some closure on this one and then move on to engage patients. I think we're approaching closure, consensus. Is there anyone on the phone? I know how hard it is when you're listening on the phone to jump in, but I know we have 3 or 4 work group members that would like to comment on what we've been talking about for the last 15 minutes or so, or raise a question. This would be a good time to do it. Okay. If you change your mind, just pop in and give a shout, and we'll try to work you in. So what I'm hearing, and I want to see if I have general consensus about this, details to be worked out, and I like Jean's implementation column, is that there's some consensus around fully utilizing utilizing existing data, obtaining data from Medicare. We talked about that last time. Cleaning it, normalizing it, getting it into shape, linking where possible claims data with other kinds of clinical information that physicians and others use, and utilizing that kind of information to identify high-risk patients, whether it's 2%, 5%, 10%, we don't have to agree on here. But these are people that are using the system now, not what predictive modeling gives us. That's another discussion. They're hitting the system again and again. Using that to, following that with health risk assessments, as Rob explained, which also get at a patient's own behaviors and how that contributes to it, and things that stuff going on in their lives, and so forth. And then starting down the process of, once you've identified them, identified their risks, translating that into a care plan that can be useful for those treating them at the bedside and in the clinic and in the physician's office. Does that seem like something that is important, you agree, and that it's kind of, we'd like to see statewide collaboration on that? And so can I assume that most of you are on board with that? Mark, any qualifications?
So a qualification that I think I'm sort of firm on is that when you're, I think, exploring the linking of the administrative data to clinical data, I don't think we're in a position to go further than sort of that level of consideration, because there are many steps that would have to be followed to go through there. I don't dispute the goal, but I don't think, other than aspirational, these first three things that we talked about are absolutely tangible, and that you can develop a work plan today in order to do that.
Okay, thank you, Mark. And one other caveat, and turn to you, Carl, in a second. So there's that caveat, which I think we all agree with. Let's be a little humble about what we can do and take it in steps. And two, the caveat that some of you stressed. Amy brought it up, others seem to agree, of being very mindful of privacy protection and patient consent.
And maybe it's, I don't know if it's a friendly amendment, Mark, but I think the question is, are these sequential activities or parallel activities? And as we work our way down this list, I think there are a number of things on this list that we don't know how to do them yet. And the question is, but should we start? And so absolutely, I think we're all in agreement on the first step. Take what we've got, figure out how to use it. But I would hate for us to wait, quite frankly, 2 years before we begin exploring the policy issues and some of the other things we need to see if we want to be able to link the clinical and the administrative data. And there's much, and quite frankly, there are other folks have already done this. But do we explore that? My own bias, I think, is we should be doing these things parallel because time is short.
I wrote parallel tracks as you were talking.
But
yes, good. That is a very friendly amendment. Are you on board with that, Mark?
Yeah, I think the linking of clinical and administrative data may be best done by the provider community with the patient, and then shared back out would be the way that I think I can get stakeholders at CRSP to be comfortable with.
And it goes back to our definition of state, because in one of the examples you said CRSP could be an example of a state initiative, and I'm comfortable with that too, but it all is in the detail of how
we are not defining state just as state agencies. I think we clarified that. Donna clarified that very well. Okay, can I call the question on that? I mean, we're not going to vote, but heads nodding. Okay, good, thank you. I want to move on because time is a factor. Let's talk about engaging patients. We started to get into that. There are many elements of that. And Joanne made a compelling case that the patient and his or her family has to be involved. It's their life. We have to understand what she gave several examples, what being at your daughter's wedding and all the things and patient preferences, but but other elements of patient engagement have to do with adherence to treatment regimens, medication fills and refills. So some of it is being mindful of protecting patients, very important, but some of it is bringing patients into the treatment plan and their families and developing outreach and templates for consent. Some of this lends itself to should we have 40 different consent forms, or is this something where there could be some economies of scale? So let me encourage some discussion around that. And are there other elements? Do these elements make sense? Is this a regional kind of activity? Are there some things that could be scaled up? Pat?
I think this is a great segue from our previous conversation where we're talking about consent and knowledge and how are you going to use my data. As docs, we will always have patients who don't want care coordination. They don't want anything. We will send a CHW out to their house and they won't open the door. That's always going to happen. And to Joanne's point, with the care plan, the patient is partly the author, or that patient's caregiver is the author, and they're carrying it around. I think we have a lot to learn from Michigan with their peace of mind registry, where patients are walking around with a wallet card that gives access to their care plan. Now, it's not as sexy as we would like because it's a paper document and you have to wait for it to get mailed to you, but if we can leverage that kind of culture to make this a normal thing, an invitation-only thing, you're a member of a privileged class, you have a card in your wallet, it starts to think, it's true patient activation, and without that, we can't really move forward with care coordination at all. Just our efforts will be completely futile.
Yeah, that's a good point, and I'm mindful of Joanne's term that she mentioned earlier, that in the real world we face trade-offs. It's not, people may want everything, but sometimes those trade-offs are, am I willing to go on the medication that my physician tells me is what I need to take, knowing that there are these horrible side effects that I'm already experiencing? How do I feel about that? There are lots of things like that. Did you have a point, Howard? Yes.
I do.
Oh, I'm sorry. Did I miss you? I'm sorry.
No, Pat, I appreciate what you said. This is Howard Heff for those on the phone. I think patient engagement is the biggest issue that we have in healthcare right now. I think that is the solution to how we will deal with chronic care management in the future has everything to do with how well we're able to engage patients. And quite frankly, we're very poor at doing it now. We see patients 3 or 4 times a year in our office for 15 minutes, or we see them for their short hospital stays, which we like to have shorter and shorter nowadays. And then the rest of the time they're in the community. And for the most part, they do not even have a document that says what your care plan is. And it doesn't matter whether you're a high needs patient or whether you're someone who simply has high blood pressure and high cholesterol and diabetes. They're largely on their own. So if we can engage patients and give them the documents and make those actionable documents in some realistic way, whether it's what you're talking about with a card or whether it's electronically, I think that's an enormous step forward in terms of being able to solve the problem of not who the high utilizers are today, who are going to be coming back to the hospital, but for the decade and the decades to come, those people who will be moving into the high utilization. And that tide is rapidly rising. And that's really that's the elephant in the room now. It's not the people who are in the hospital now. It's the baby boomers who are 65 to 75 years old. I'm part of that club, who need to be attended to. So I think that this issue is not it's a very important one. I don't know if we have the solution for patient engagement. It's a lot of different strategies. Most of them done absolutely at the ground level, though.
Laura.
I was just going to piggyback on the comments already made, and even as we think about the order of the way we have it, certainly developing a standardized approach to patient outreach and consent, including templates for patient consent, will come before the enrolling of patients. And how we outreach and sell the card to the patients will be incredibly important for those that choose to be care managed versus those that don't. And you've all heard me mention HQP before, but in their experience, only 1 in 4 said yes. That was it. And in their Aetna Medicare Advantage plan, it was half, but that was a controlled cohort of individuals. They were pre-identified, 1,000. But just in looking at the administrative claims data, only 1 in 4 said yes. And so is there anything about those individuals that say yes that we can work on to improve the yes rate so we get it up more than 25%? But our order needs to change, and then we need to think about what needs to be included in that outreach and education to engage patients successfully in the care coordination.
I don't know if these grids the boxes are mutually exclusive, but that's why I have a trouble with 2 being a state, because it can be a campaign at a state level, but it's local, 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 and the physician-provider-patient relationship that needs to be involved too.
Yes, and there's nothing magic about the order of these. We can rearrange them. You just gave a suggestion, so that's all open for discussion. Other comments on this? Yes, Pat.
Quick comment, and that is we spent a lot of time talking about data and trying to find these patients. We have to think about what do we do with a patient who self-identifies and says, I need a care plan, or a doctor who says, I have a patient, she's 70 years old and demented. Her husband, who used to take care of her, just died. She isn't in trouble now. She's going to be. She needs a care plan. How do we what's the entree for that patient into care coordination?
Okay.
May I then just ask a clarification? I think Pat has put an important idea on the table. Did we bring 2 to greater specificity? That is, in connecting Debbie's point, there may be a statewide, a state role, a state level. Thank you, Greg. A state level role in creating a consumer campaign around allowing access to their care plan. But the, if you will, day-to-day patient-to-patient education is happening at the local level. Is that a fair amendment to number 2? I don't know who offered up number 2. I don't want to twist it. But there is okay. There's a state role. Yeah, thank you.
The comment, I'm not sure it's going to make any sense, though, because I'm not sure it makes sense in my own mind. We did this a couple years ago around, as did most states, around the MOLST forms, right, around the Maryland Orders for Life-Sustaining Treatment. We had a huge development process, public campaign effort, trying to get people to fill them out. And that really is part of a care plan for one highly specific situation. Judge how successful it was. These things, though, do have a tendency to affect the language people use. And as I look at the sample care plan here, I hone in on one part of it, which is the goals part, which is not something we're going to pull out of electronic data. It takes a conversation. It's also something missing from 99.9% of the patients who I see. And most of them have, and maybe that's unique to my population. They haven't had the conversation.
Have 100%.
They haven't had the conversation. It's not in the record. And it is a relatively recent part of medical education, I think. I'm being fair in saying that. So even if only a quarter of people fill out a care plan, by altering that conversation, that kind of assessment and goal can have repercussions far beyond the specific document that it's part of. It's very fuzzy, but in putting this together, we're really trying to change language and discussion at a much broader level than the physical component of whatever we put together.
Yeah, and I mean, thank you. I mean, I think we've spent a lot of time talking about, and again, I want to wrap this part up in about 5 minutes because we got 2 or 3 more, and I'm watching the clock. We've talked a lot about patient consent, and that's very important, and templates, and that's very important. I just want to give you one example from my experience to illustrate what I think is another important element of patient engagement and involvement. This is a real patient, North Carolina, pre-ACA, pilot, private sector run, get 100 patients enrolled in coverage, insurance-like coverage, but there was reciprocity. but they had to do something to improve their health to get this free health care. It was basically free health insurance, no premium. And so there was one patient with hypertension, diabetes, morbidly obese, heavy smoker, 3 packs a day. You get the picture. Okay. So they got him to sign a contract that he would enter a smoking cessation. It's step 1. Well, I can remember if it was the patch or, or the drug, Chantix or whatever it is, but something he would try in order to get this. And then the next step was, you got to agree to glucose checking, and here's how to do it. And if you keep doing these things one at a time, not all at once, and it seems to me part of patient engagement, not scolding them, but getting them involved in the risk factors in their lives, and in the treatment protocol and the fills and the refills and stuff. Does that make sense to you as part of patient engagement? Not in a punitive way. Fozzie.
But I think what you're saying is that the patients have skin in the game.
Yes.
And I think that that is a very important part. And I think if you can get someone and their family, so sometimes it's not necessarily the patient, but it's their family who are being invited in to come up with that plan,
yes.
then they have skin in the game, and they make it according to what they want and what makes sense for them. So I think if once you take the trouble of making the care plan, people will follow it, but it's the investment of time to put that plan together that is sometimes hard to do. When you have physicians who, are seeing patients every 10, 15 minutes, I think that's the hard part of how do you engage physicians to commit the time to have those very hard conversations. And that's one of the things that we haven't talked about is how do we engage the physicians who should be at the local level doing this work. But I think once you commit to it, you'll see that you'll move from that 25% to 50%. But that's the part that we have to think about too, is how do you entice and reward or whatever the physicians to do it.
Okay. Oh, yeah. I'm sorry, who am I missing? Oh, Ernest, yeah, please.
Just a quick comment. So I'm taking a real hard look at the patients who are significantly at risk for going back to one hospital that we're working with. And an example is, so when I look at this, I say, how do I create a care coordination plan based on the data that I would get from here for a patient who has one of them that has been there 30 times to the hospital, and all because he's homeless, he doesn't have a home, et cetera, et cetera. Then I've got a lot of readmissions people who don't come back because they have one person calls the EMS all the time because it was the same time that he ate in the hospital, so he wants to go back and eat. I mean, those are patients that, in terms of driving costs, and we looked at everybody who's been back into the hospital 8 times or more in the last 2 months. They're driving the cost of these hospitals that we're looking at. Every last one of them has needs and data that I need to know that's not going to come out of the data that I'll get here. And I can't, and in order for me to actually to create a care plan based for those people, now that's not everybody. But when you look at the numbers, they're sitting down in this 1 to 2% of patients who are driving a huge amount of cost over here. So we've got to solve that problem. And so when we create a care plan, we've got to look at data, just not data from this, certain sources. We've got to look at data across a lot of different sources, because if I knew that this patient who just walked out of the hospital needed a care plan that included this person actually needs to get into a home situation and somebody follow them. So that's one thing. Now, the other thing I wanted to say about patient engagement that we found is that it's trust. It's the behavior changer for a patient. It's trust. If they trust their doctor, the doctor says this person is going to help you coordinate, that's good. But what happens is they get people from their insurance company who wants to manage them. They get people from the hospital who, the case manager who's calling them. They get a lot of different, and I put on a slide, a lot of different arrows. They need one trusted source. That will help at least the patient population that we have And these patients are all different. Like you're going to have some people who are okay with everything. But I'm just saying that to get those patients engaged, some of the more difficult ones, you have to develop lines of trust. You have to have data other than just clinical data to be able to create the type of coordination that you're going to need to manage them. So I'm just saying that. And even patients that you don't even think that would need that, need it. Because you'll find out they end up in the hospital because their grandmother didn't come by to do X, Y, and Z. And well, no, they're young. No, it's the grandmother whose son didn't come by that day, and X, Y, and Z happened. So we have to take all of those things into account. So we do look at literacy and behavior. But I'm just saying there are data sources that we need here to integrate into our care plans. There are trust issues and behavioral issues we have to think about in terms of patient engagement, and that's inherently local.
Okay, and it's not only inherently local, thank you, Dr. Carter, but also what you're saying, what I take out of what you're saying is that a good care plan, and Joanne made this point, she gave some examples, has to include data from input from outside the medical system in the social system of needs such as hunger and homelessness and various other abuse, neglect, whatever, to be workable, particularly in low income, but not exclusively in low income, also for the elderly across the board. Very important point. Could I sort of call the question with regard to, it seems to me, but I don't want to, correct me if I need to adjust this a little bit, that there's some agreement here that on things like number 5, preparing health risk assessments, and number 4, a standardized approach, including the templates, that there are enough economies of scale and where a common approach might work, that this could be, I think I'm using Greg's term, a statewide kind of thing, whereas other things, enrolling patients in care coordination with providers with whom they have a relationship is more of a local type thing. Does our placement seem to work here? And before we call the question, is there, and noting that there are a couple of new things, like the ones that Ernest just brought up, that have to be worked in. Yes.
Jack, I wonder if I could maybe put a finer point to that.
Please.
There are a couple of things. In number 4, it's about a standardized approach to patient outreach, a standardized approach to patient consent, and I'm going to jump to number 6, a standardized care plan. Yeah. And I think it would be really helpful to us to hear your thoughts. Is standardization a good, helpful, useful thing? Or, as some of you have heard me say, does that only work if we were coming over on the Mayflower and starting over from scratch? Could you give us just some of your thinking around those 3 areas? Is standardization what we ought to be moving toward, or are there dangers we ought to consider?
Pat.
It has to be standardized in where we find it, to my colleague's point. It has to be a reliable source of, if it pops at me in my EMR from Chris, great, but it's always in this corner of the screen, yeah. That sort of thing.
Yeah, so that's an important distinction, because I agree with that, because care plans by their nature won't always look alike. They won't always have the same elements in them, because patients need different. But in terms of structure and placement, the example you gave, it could be standardized. So there's a nuance here. We don't want to be a one-size-fits-all for the care plan, because every patient is different. But there's certain types of things like that. Does that make sense? What?
So I agree with Pat. I think the tool has to be standardized. I think the kinds of information we want to know about the patients are actually the same. We recognize the patients are different, but the kinds of information that we want to know about the patient are the same. And 2, as we think about long-term interoperability, if we don't have a standardized care plan, we're never going to get there. And so as we think about CRIS potentially as the vehicle, even if the data owners or the users of the tool still own the care plan, the potential to pull it into CRIS so it's visualized by multiple organizations that may not be on the same EMR, if that care plan is not standardized, we won't get there.
And then can I just make one more? So I also think, this is Bobby, so I also think if we think about it as if with other industries, so in the airline industry, they have checklists, so they make sure that they don't forget really important things. This is kind of like our checklist, or in the operating room when you have a timeout. So standardization forces that function to do all of that.
Although to exercise a little caution there, you know, I think that there's not enough science, and we're not far enough along to know what all of those questions should be. For instance, adherence to medication. You really want to know that and have a discussion with the patient, and you're getting electronic data in that's telling you whether they're adherent or not. But how do you describe that adherence? It may be different ways, and we certainly don't know the best way of doing it. Is it a 5-point scale? Is it good, bad? I mean, there's not enough known. I think the good part here is a coordinated approach. Yeah, definitely. There's things that one could already say that need to be there.
Howard, and then Mark. Go ahead, Howard. Go ahead.
So absolutely, I agree. You know, there are some key elements that I think universally we agree in terms of the architecture, but you're 100% right that we really don't know where the real value is going to come in terms of outcomes until we get a lot more standardization and can look at those things analytically. But that doesn't diminish the need to start someplace. And starting with the basic stuff and then building from there, I think that's an iterative process. So you're exactly right.
So working in a field in informatics where people come with problems and jump to tools, right? A tool by definition means somebody has to use this particular thing. And I don't think we're there yet. I think what we're trying to do is to develop a care plan approach. We're trying to collect certain kinds of information and be able to share with the patient and with other providers important features that aren't easily available. And it's not easy, the problem list, med list, an allergy list, right? Even that's hard. But to think that when I hear a tool, I then think we're going to have to hire people to actually be the ones who operate that tool. And I don't know that I'm there yet.
Okay, Laura.
I will just say, having worked at VHA, Veterans Health Administration, for some time, and the number of care plans based on the service line, and then VA's attempt to reconcile all the different care plans, it was in the hundreds of millions of dollars to try and do that after the fact. And all the care plans had elements that were the same across. There were nuances with the specialty and the service, but for the most part, the big things. I agree to your point on, well, how do we answer the questions, but at least the types of questions that should be answered. If we don't start thinking about that, it's going to take us, and that goes to Carmela's point of what do we do in parallel and what do we do sequentially. And there are elements that we can start looking at now to start standardizing what we collect. And to Howard's point, go through that iterative process as we learn and start evaluating what we're collecting, what's useful, and build on that.
Okay, Rob. Oh, is there somebody that hasn't had a chance that I left out? I'm sorry, Rob or Gene.
I'll be real quick. The one point I wanted to make is a lot of particularly my hospital-based doctors will work in different institutions, or they might work at like Patients First, and then they also moonlight somewhere else, or vice versa. So if you make the care management plans as standardized as possible, the probability they actually use them, fill them out, and make changes to them goes way up. Whereas, and I already hear complaints from physicians who go, yeah, I go here and I have to use Epic, and then I go here and I have to use Athena, and I have to remember which one I'm using. So we weren't smart enough as a society to standardize the EMRs. We could have made life a lot better if we just used Dr. Herrera's VA system for everybody. It probably would have saved us a lot of money too, but we didn't do that for various reasons, so maybe we can avoid making the same mistake with these. And I also want to kind of back up what Mark was saying earlier. I do think we should make the list of everything we want, but then we should go to the technology people and say, what can you do, and do what we can do, and figure that out giving them the whole list so they know it, but let's see what they can do and focus on what they can do, not on what we want. Because when we do my experience has been with technology, when you try to get them to do what you want rather than what they can do, you end up with a mess.
Yeah, and it's an iterative process, and I hear what you're saying. You go as far as you can go, but then you try to build and learning, and I think we're reaching some closure on this. What I want to do, because again, we have about 8.
Well, there are people who've already built them and spent millions of dollars already building them, so let's not forget about some of those.
So the wording on here really needs to be clear, because I can't agree to a standard tool, common elements, same information that's user-friendly, yes, but investments have been made, to Donna's point, and we can't dictate that everyone change after those investments are made.
I'll jump in here. If I'm listening, I think we have a split. Standardization, a good thing, but the issue becomes: are we standardizing around elements, where, to Greg's terminology, then we create a single visualization of those elements, perhaps somewhere, versus, I think another view in the room, go for the standardized tool. But I think we're still of split mind, what I'm saying.
And I wasn't really suggesting that we shouldn't standardize, so I was just saying that there are people who have already developed tools that could be put to use as a standard platform. If one were and they might be fed by somebody else's tools electronically. It's not that they would necessarily have to start with somebody sitting there typing it all in. But I wasn't necessarily saying that we shouldn't have a standard tool in the short term, while we figure out how to make things more interoperable in the long term. So anyway, but I agree that with Carmela's assessment, that there's an interest in having care coordination done in a collaborative way, but not consensus on exactly how that should be done.
Is there a metaphor in the entire development of the digital age, in that early on, DARPA and MIT and a variety of universities all agreed that there would be a standard protocol that everyone would use, and it made it interoperable, the Internet. So we got the Internet. Sometime later, that Microsoft guy, what's his name? Yeah, you know who I'm talking about, said, let me take this operating system and make it proprietary, because if I can get more money and invest in it, I can make it a great operating system, or the other people. And they did wonderful things with proprietary things also. But both have to exist. I think you need to have both the proprietary investments and the growth for all those things that are like that are big investments and require special interest and are very useful, and also this piece of interoperability that everybody agrees. And if we're going to all communicate with those tools, we have to have one piece that links it all together that we all agree is not proprietary. So I think that's kind of at least where I'm thinking, is that this is not takes the place of anything that any existing enterprise has already developed. It just provides a vehicle for simple communication of the core elements from any one of those systems. Does that make sense?
Yeah. 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 Anybody on the phone want to join in that hasn't had a chance?
Hey, Jack, it's Lori.
Hi.
Hi. If I could, I'd like to comment actually on number 3. Didn't get a chance to earlier when that was being discussed. And I just wanted to, remind people of the role of community organizations in this whole discussion. I listened to some of the comments about the percentages of people who consent for care coordination. And in our chronic health home, we have very, very few people turn us down. And I think that's because we actually have the benefit of working with these people every day, pretty much, day in and day out. So we can find out how they see it as a benefit to them. So I just don't want to lose the fact that if you can refer to the community organizations, or even better, if we could do some in-reach while people are in the hospital prior to discharge. And again, I'm focusing on behavioral health because that's the world I know. if we could start establishing that relationship, even if they don't consent right then and there, because, you know, physicians' offices, they're busy. People don't tend to have the time and the relationships that we have with people. So if we can start that early on, the chance of getting that either while they're in the hospital or down the road are so much greater.
Okay, thank you. Ben.
So I wanted to maybe put a plug in not for standardization, but starting with a focus on consistency. I don't know as much about the evolution of the clinical standards, but I know a whole lot about the evolution of the administrative transaction standards. That what happened there was that we moved towards standardization, but we took basically the approach that was taken was standardization was taken by, we'll take everything that anyone wants, and therefore, and thus it will be, everyone will be agreeable to it, which also ultimately led to some, you know, pretty complex, complicated transactions. And I think you have to recognize, you know, to get the positioning that Dr. Zapp proposes, you know, we want it positioned in exactly the same way. That's a goal, but it may not be achievable in iteration one of whatever, you know, it comes out. That even achieving consistency without what I would call absolute standardization, where the transactions are identical. And I think someone made a comment about, you know, really a care plan is dictated by the condition and the conditions that the patient may face. It may be hard to achieve. I think when we thought standardization sounds great, but it simply is not the union of what everyone wants, and that leads to probably some, you have to give and take in that process, and maybe we have an incremental step in between to get to that goal.
So Debbie, are you comfortable with the way this is going? Because we have to wrap up in just a few minutes. We've got a whole bunch of people that have been kind enough to come here and talk to us, and I don't want to keep them waiting more than 3 or 4 minutes. But are you comfortable with this nuance, that, you know, common elements, consistency, but still room for improvisation and variation?
Standard tool that I have concerns with. The standard elements, the sharing, I don't have any issue with that.
All right. Does everyone agree? Okay. I kind of think, unless anyone, looking at the co-chairs and Donna, unless anyone disagrees, that we've kind of come as far as we can come today in terms of the time constraint. Thank you. It was a lively discussion. We got a lot. We got a lot of good advice on how to go forward. We got a consensus on a number of things with caveats. We got friendly amendments, which were very helpful, all of which I've tried to scribble down as best I can, and we'll try to make some sense of. So thank you. Now,
and I just want to make one comment about that before we start into the panel. So one of the things that we need to do is to take where we think we have consensus to move forward with developing a budget that could be applied to the implementation of this, because under the BRFA from last year, we were allowed to put $15 million in hospital rates before the end of this fiscal year that could be utilized for implementation. So as we move forward, we have to keep that in mind, because we will, while we don't have to spend the money before the end of the year, we need to collect the money. So we will begin to take some of the information that's coming out of here to develop a budget that could be utilized for a statewide approach to collect the money that could be used to start this process.
And I wonder if I could suggest a process to get us there, because time is short. I've heard a lot today. If Jack would let me, I'd like to play with this table a little bit. And I wonder if it's now not time for us to split this table into 2 pieces. Those pieces where we seem to have some consensus and are very specific in ways that would allow us to develop that budget, and other ideas that are still on this list that would require further development, further specificity to allow us to develop a budget. And maybe there's some work we could do between meetings where we want your okie dokie on the first half of the list. Did we hear you correctly? And we can move toward developing budgets and what are we talking about. And the second half, where we'd be asking you via email to come back and help us with very specific ideas. Otherwise, those would begin to fall off the list. And of course, we can't do everything on here. And then that leads us back to making final prioritizations of a handful of items. Does that sound like that might get us, Donna, where we need to go timely?
I think so.
Yeah, that's great. And one other note, and then we're going to start, just so you don't think I forgot about it. This group is going to have a report, and it's going to be a report from you to HSCRC and Chris, and it's going to give your recommendations. But I'm going to help you with that by I have started drafting, as I listen, drafting sections of that report. It's your report. I'm just the pen that gets it started. So you'll begin to see some of those come your way. We probably won't have time at the meetings because there's only one more left to do that. But through review and email, and you mark these up and so on, we will get your input so that it'll be your voice. Because so I just wanted you to know that's in the works. Okay. Our first panel, we have 4, and I have to stress each panel is no more than 15 minutes. I'm sorry, but we're so glad you're here. Is the physicians panel. Dr. Haft is going to be on that panel, I think, with 3 of his colleagues. So if you could take the seats between Ben and Pat, and you have 15 minutes, but any combination of you that wants to present, make sure that they have microphones, please. We can share some with you. We're eager to get your advice. Yeah, sure. Yeah, you mentioned that. Sure.
Also, if panelists send a set of slides that they wanted on the projector, you could just mention, and I'll try to find them in our text.
If you don't mind.
Yeah, we had 2, 3, 4.
We'll get your slides in 1 minute. That's it. Okay.
Okay. So I'll start, and I'll take 2 minutes on 2 slides so we can talk to the real physicians on the panel. Could you just go to the next slide, please? So I just wanted to...
Can you introduce yourself?
Yeah, I'm sorry. I'm Craig Bem. I'm the Executive Director of MedChi Network Services and the 3 accountable care organizations owned and operated by MedChi. I just really wanted to emphasize the point that I think we're all going to be pleasantly surprised if a program is designed correctly by how quickly and hopefully thoroughly it will be embraced by physicians of all types. MedChi has a lot of experience now over the past few years, coordinating care for 27,000 assigned Medicare beneficiaries, supporting meaningful use, EHR implementation. Past couple months worked with our friends over at MHCC and the Learning Collaborative and CRISP on the Transforming Clinical Practices Initiative. We're developing LOIs and partnerships with groups like Anne Arundel Medical Center and CRISP. And I think there are a lot of really good kind of grassroots, physician-led and provider partnership programs out there. And based on all that experience, the next slide is just 5 quick lessons learned that we'll get into a little more detail over. So I think that the keys, kind of a very simple, straightforward, standard program that can involve any providers, provider types, entities that are interested, that is transparent and fair, I think is going to get a lot of traction. And I just want to emphasize maybe that bottom bullet, simplicity, because Dr. Haft and Dr. Parabembo are going to emphasize 2 others. But I think the way that we get this to stick and be sustainable is by making it work within workflows, within time constraints, within incentive programs. And if we can do that and maybe take some very good baby steps, I think we'll have really great adoption and do some wonderful things.
Great. Thank you, Craig. Howard, are you next?
Go ahead, Hal.
Sure. I'd like to speak to interoperability because you would expect that I would speak to that. I think this is a wonderful time to be around in healthcare. I think we're really at a place where where in this state we can serve as leaders and examples to the rest of the country and how we can interconnect the information between the well-established silos of healthcare that exist. And I think that's ultimately the solution to how we're going to improve health for the whole state, if not the nation, if not the world. And right now the winds that are at our backs, the opportunities are really rife in the state. Things that are occurring now, the fundamental one, the reason we're here is because of the Medicare waiver. We've gone to a global budget. It requires now that we take a different look at how we fund and how we care, how we fund hospitals and how we care for the people who are in the hospitals. We want to do more in the communities, less in the hospitals, and it puts the responsibility on the communities, the community providers. Community providers were not in the past at all incentivized to do that, however, but right now we're in a position where the CMS has given us the benefit of a chronic care management code, not yet adopted by very many, but one that we could stand as leaders nationally in the adoption. It's a way to sustain the funding for chronic care management, to sustain, not just to start a pilot project that doesn't have ongoing funding, but to find federal funds to sustain the ability to care for individuals on a chronic basis. ONC has given us 2 mandates, one the Meaningful Use 2 and I think 3, that said we will connect up the dots between our patients, ourselves, and all the people in the care management programs. That we'll do that through the EHR. They've given us a second mandate that said we'll do that using CCDAs, which are structured devices that are the essential elements, not a big care plan, but provide the structure for which a care plan can be created. And they've done the heavy lift on that, on creating the architecture for that. We just have to fill in the boxes more or less. Our IT colleagues will tell us it's not that easy, but I'm going to make it sound easy for you. We've all been in the trenches. It's not that easy. It's a lot of butt in the chair time to do that. But I think now is a great time to be able to do this. And I would say right now, and I'll zip it up after this, is that if we're going to start talking about budgets, I would leverage what we have now with CRISP, and I would ask CRISP, I would put that on the top of the budget, to ask CRISP to develop or provide them with the sufficient funds to create a correct CCDA, to be able to make it interoperable, to leverage the Practice Transformation Network grant if we're fortunate enough to get that, and MedChi and their resources, and really make the state outstanding in terms of being able to develop an interoperable care system.
So my name is Jim Rost. I am a medical director of Shady Grove Medical Center, Patient Safety Quality, and also a frontline heads down physician as a neonatologist working in 5 of our state hospitals. First of all, I want to say this is great work. It's highly complex. We know it's a high priority, and it's foundational to good, safe care. So I applaud the efforts. Through our lens, care coordination not only provides the value proposition that has been mentioned, it also, in my mind, deals us a potential patient safety problem each and every day. We've seen the one loose end that comes back to harm not only patients but their families as well, and this we know is not uncommon. So I think that the more we can eliminate or mitigate or reduce to zero these issues, that's going to be better. I just have a couple take-home points that make the interventions multidimensional and have them span our clinical settings. I think it's important, given the way healthcare teamwork is delivered, we need to update the way we view teamwork from single clinical settings such as the OR, the ICU, the ED, even a primary care physician's office. We need to change thinking how it encompasses multiple clinical settings where team members might not ever know, meet, or see each other. We need to engage and excite patients in a positive way. We know fear is not a sustainable motivator. That was mentioned. Using interprofessional nurse-coordinated team models, using holistic family-centered approaches that do use protocol-guided streamlined care. It's challenging, and it requires a system designed to facilitate doctor-to-doctor collaboration. And this, again, highlights the need for a robust HIT solution that needs to be strong and secure. that allows us to communicate with each other and share information, allows visibility into our patients and facilitates care across all settings, that allows for smooth transitions of care from acute to chronic care settings to home and home-based services. And one, I'll just finish with one that I consider most important, that perhaps even predicts what non-medical or personal family challenges are limiting coordinated care, like was mentioned, transportation, a place to call home, and if you have a home, is it heated and is it air conditioned? If we're going to improve coordination and collaboration in our state, our workflow needs to be structured to allow time for communication with each other, and as mentioned, our reimbursement system needs to recognize the value of this aspect of care with incentives built in and rewards for improving patient health and lowering costs. A number of physician groups have advocated and supported financial incentive programs for physicians performing these tasks. Thank you.
I'm Dr. Paravemba. I'm with First Colony Anesthesia Associates. Just want to work off some of the things Jim said. We work in the same hospital at Shady Grove Hospital. Heard a lot about care coordination here today, and the work is fantastic and it seems very complex. And the area where I wanted to concentrate here is how to incentivize better coordination of care through the hospital. I think we've even heard to some degree the value of coordinating in the hospital setting as a place where patients are in a specific area. It's easy to get to them, it's easy to talk to them, and engage the patients there. To that end, our national society has specifically created a model called the surgical home model, perioperative surgical home model, which basically concerns and addresses care coordination, value-oriented care for surgical patients going through hospital care. The value in this type of care is that, first of all, there's early engagement prior to surgical care where we can take care of chronic illnesses. We acquire lots of data when we are performing perioperative testing and so forth. And I tried to pose a question when we were talking specifically about data. One of the things that we've started to do is collect data on patients going through surgical procedures. And that data may be very valuable integrated with the data that's collected by Chris. In other words, there may be provider data out there that we can tap into that specifically addresses outcomes and addresses patient morbidity, chronic illnesses. The idea behind the surgical home as an extension of the patient-centered medical home is that we as physicians there become more perioperative. We take care of the physician before and after surgery. And these are some of the programs that provider organizations are creating that we should not undervalue. And as we create incentives, we want to make sure that we integrate those types of programs and really allow them to thrive, either through funding or different payment methodologies, gain-sharing methodologies that Carmela and I have discussed, because often we do not see what value specific providers. We have preconceived notions on which providers may provide specific value to specific patients. But there's a lot of work out there that's being done that is kind of under the radar. And we need to utilize that with the care coordination efforts that we are discussing today. I had some slides, which obviously I don't think we got, but so that would have been easier. But the basic gist of it is that as we create the incentive plans, either gain sharing, shared savings, that we allow specific physicians who treat specific diseases to come out and bring out their innovations, some of them even disruptive. I think when the patient-centered medical home first came out, people didn't think that that was going to be necessarily effective, but we found otherwise. Now there are innovations like the patient-centered surgical home or perioperative surgical home that really addresses patients at specific sites of service, collects valuable data, addresses chronic illnesses, and there's a lot of evidence to support that the way they're treated or cared for along surgical, in the operating room and in the post-surgical arena, really has an impact on their function and their patient satisfaction and so forth, and has long-term effects. So that's all. Thanks.
Great. Thank you. I think that we have, if she wants to do this, audio-enabled Patty Brown, a member of this work group. But Patty, can you hear us? And if so, do you have any comment either for our physician panel or on anything else that you'd like to add before we move on?
No, I've heard you very well for the last 2 hours. Unfortunately, you weren't able to hear me. But no, I have no additional comments at this point. Thank you, Jack.
Oh, okay. I'm sorry. I think probably we didn't hear you, and I apologize for that. But thank you. Okay, we have time for maybe one question because I'm really watching the clock, or comment. If anyone would like to, any member of the work group would like to ask a question. Okay, I think we'll move on. Thank you, gentlemen. Excellent presentation. We appreciate you coming to advise us. Our next panel is on long-term care and post-acute care. We have several people, and the floor is yours. Maybe we can loan a chair. There we go.
We'll do a duet. They'll never forget it.
Okay, who would like to lead off? And please introduce yourselves as you speak, for all.
I'll start.
Good.
And I think that I'm turned on here. I'm Carmel Roque. I'm the president and CEO of Keswick Multicare in Baltimore City. We are a post-acute care provider, Medicare, Medicaid, adult daycare, and assisted living. And mostly, I don't have a lot of prepared remarks. I want to respond to what I heard today and just share that one of the things I didn't hear when we were talking about care plans, I did not hear in the list of organizations that historically provide care plans any mention of post-acute care providers, Medicare, Medicaid providers. We are experts in advanced medical disease. We have years and years and years of experience now doing advanced disease care planning. That is what post-acute care providers do in Medicare, Medicaid facilities. And so there is a very, very rich tradition and available data that can be readily shared on care plans that work for folks that have advanced disease, who have multiple comorbidities. The other thing, when we were talking a little bit about identifying high-risk patients, Medicare patients, all of the patients who come to a Medicare certified SNF for post-acute care are high-risk patients, otherwise they would have gone home. And so we already have an identified group of patients with tremendous amounts of data collected on them and systematically and consistently reported to the state through the minimum data set. And there's this rich collection of data, patients already identified, care plans already customized, and I would just like to suggest that post-acute Medicare, Medicaid providers not be left out of this conversation as we go forward and be viewed as the resource that we are. And I think I'll just leave it at that. Thank you.
Great, thank you.
Okay, that's a perfect opportunity for me to follow up. Thank you for the opportunity to share the role of rehabilitation services, of which Keswick has many. And those are my slides, so you can advance.
Could you introduce yourself, please?
Marlene Riley. I'm an occupational therapist, but I'm representing the interests of rehabilitation services across the continuum. There's no one else on any of the work groups with physical therapy, occupational therapy, or speech language. And as we discussed, care coordination and what happens to the patient post-acute, then we see that as a really significant role. So there are a few things that I want to highlight, and part of the theme that I know has existed is what do we do now and what do we do later. And I think there are some things that I can bring to your attention that we could do now. First, just recognizing that some key points are functional mobility, self-care, and cognitive function. And those are all areas that rehabilitation, OT, PT, and speech address. The rehabilitation services are provided across the continuum: acute care, post-acute care, all of the settings, and also in behavioral health. And they have significant contributions. Often in the inpatient stay, the initial eval that's done by rehab is where does the patient go next? And should they go to inpatient? Should they go to skilled? Should they go to home health? So that's a really important transition decision that's in the role of the OT, PT, and speech. Next slide. One of the things that I want to make the HSCRC and members of the work group aware of is that there is a federal therapy cap on Medicare B. And what that means is that those are the actual dollars, $1,920 a year is the cap for OT, and it's the same dollar amount for PT combined with speech. So that is all of the dollars that are allotted unless exceptions are requested for individuals who require post-acute Medicare B. Part of the complication there is that observation days use up Medicare B, outpatient. There are a number of different parts of the continuum that use up those Medicare B dollars. But with our rate setting system in Maryland, there's an inequity. If you look at outpatient dollars and you consider the cap, that means that I have an example listed. There can be a range of $60 for a 30-minute treatment or $225 for a therapy treatment. So what that means is that if there's a cap to be met, then there's a huge difference. It could be a little less than 10 visits per patient that goes to hospital A outpatient, and it could be almost 40 visits per patient that goes to another facility under our rate-regulated system. So I think that's a huge issue that, as a state, we need to address. Next slide. Another additional barrier that I won't talk too much about because we've already discussed this whole issue of tools, standardized tools. That's also an issue within rehab. It's really difficult to look at the specific distinctions between what works best. Do we go to skilled next? If you have a TIA, do you go home next? So there's a lot in the literature, and at the end of the slides, I've just listed some additional reading just to represent there's a lot in the literature in making those decisions in terms of where the patient should go for post-acute. The other thing to mention is that as a faculty member at Towson University, we work very closely with University of Maryland and the other state universities, so I think that there's a role for the state university in the workforce requirements. And in fact, interesting that you're from Keswick, we have an interprofessional education opportunity in April where we have workforce from PT, OT, speech, nursing, all the different post-acute care providers that will be doing an interprofessional training at Keswick. So I think we're doing a good job with the interprofessional, but we can do better with that. And we can do better with professionals that have been in the field for a long time who haven't had that IPE kind of experience. And then the other thing to acknowledge is that we're doing a lot within the community. So yes, things fall off when there's that transition to post-acute, but the biggest place it falls off is where do they go after they're discharged from SNF or after they're discharged from home health. So there are a lot of dollars that are being spent up front, hospital costs and immediate post-acute care, and then they go to the community. So maybe that whole acute episode took 3 months, but then they have the rest of their life. And that's where I think we as a state really need to look at how some dollars can be invested there. One of the centers that I wanted to highlight is just that at Towson and also in collaboration with University of Maryland and Notre Dame and some of the other schools, we have a Gateway to Better Balance program that we do with the Baltimore County Department of Aging. And as part of that, we've worked to set up fitness centers in the 19 different senior centers. And that's been working with exercise science and a variety of providers. We also have an Institute for Wellbeing that's right in downtown Towson. So if you go to Towson Mall shopping and you drive by the WTMD scroll, then that's where our Institute for Wellbeing is. We have programs there for individuals who they've had their stroke, they went through inpatient rehab, they finished home health, and now they're coming and they have supervised programs for support for their stroke. And one of the
parts of this that I think is really very special is that it's an inclusive program and that we have families where they can work out together. Right now we have 2 families, husband and wife teams. In both situations, it was the wives that had strokes and the husbands were their caretakers, and they come as a couple, and the husband works out and the wife works out, and it's all supervised. And I think those are the kinds of programs that can help us to back in to trying to prevent readmissions and provide better services at the community. Thank you.
Great, thanks.
Good afternoon. My name is Dennis Hunter. I am the Vice President of Brook Grove Foundation. We're a multi-campus provider in rehab, long-term care, and assisted living. So it's a big topic, isn't it? Big topic. So we only have a couple minutes, and I kept rereading the focus of today's meeting to leverage what we have was one of the primary goals. And I'll say that on the skilled side, the rehab side, short stay side, Medicare Part A, one of the challenges our industry deals with is access to information. Interestingly enough, in today's world, it's easier to communicate than ever. We have more information to communicate than ever, but it sure seems hard to get the message across at times. There's no doubt about it. And we have this fine balance. We heard some discussion today and earlier in the meeting about protection of information, privacy of information. We're all concerned about it. And if you look at the apps on your phone, you realize how much information is being collected about you every day. But we're very, very protective about healthcare information. You just can't get it till after somebody's discharged. It's very challenging if you want to leverage a care plan or data that's been gathered together in a hospital setting, in an acute setting, and prepare for that patient to come to you and well-resource that patient if you can't get the information a couple days ahead of time. It's very challenging. It's been challenging enough where at one point, within this last year, I went to a hospital and I said, you know, is there any way we can get access to that information? No, you cannot. Well, I'm just truncating it. It was a very nice conversation. The fact is, if a patient comes to us from you, we don't know they want to go back, so they're not your patient either. Now, there's a bit of absurdity involved in that. So if we want to leverage information, let's find a way to make the information we have available so it can be used in a much better and more effective way. So that's number one. There's kind of a systems issue that I've observed. Now, Brook Grove has a campus in Montgomery County. We're in Sandy Spring. We have a campus in Williamsport, Maryland, which is on the other side of Hagerstown. And they're like 2 different worlds. And there's a good reason that they're 2 different worlds. One is a rural area, 1 hospital, however many skilled facilities there are and assisted living facilities, but there's 1 hospital. Who's the leader of the pack? Well, the hospital steps up and says, we're going to help coordinate this effort. We have a lot of things to talk about. And it goes really, really well. In a metropolitan area, how many hospitals are there? Who's leading the pack? There's a gap. There's a missing piece that allows us to coordinate and communicate effectively together. We can talk about data all we want, but ultimately, there's no substitute for sitting down at a table and finding solutions together. So there have been times in the last year when a task force of our team meets with the hospital and says, we have a problem with wounds, and we want to create some accountability between the 2 of us to solve it. We're going to own part of it. You guys got to own part of it. Let's sit down and talk. Data doesn't do that for you. There's a piece in the metropolitan area that's missing when it comes to coordinating that kind of effort. So what you end up having is 10 hospitals, 50 skilled facilities, each one kind of wanting to engineer their own system. It's very ineffective. And even on the simplest things, whether you're talking about getting information to a discharge, whether you're using e-discharge or all scripts, that's great.
Some hospitals have their own system. So that's kind of just a systems issue. And another point I think that I want to make, and then I'll let a couple of my other peers continue the discussion. Electronic health records. There was a comment earlier, I believe, from this gentleman over here that was talking about all the different ones that are out there. Well, I think it's even worse on the skilled side. There may be 100 to 200 different options available. That, combined with no incentive for skilled facilities to actually purchase them. You know, Brook Grove has electronic health record. It's one of the few. It's one of the few. And even then, the portability of the data, I've heard the word standardized used a lot. And standardized sometimes gets a bad rap. Portability is what we all want. We don't care if it looks exactly alike. The easy way of getting it from one place to the other is have it look exactly alike. That's the easy thing to do. But we all want portable information. So I just kind of wanted to go those kind of three things to put out there for you guys to think about.
Great. Thank you. We've got about 6 or 7 more minutes. I'm sorry, you know, but we do want to hear from all of you.
Good.
Okay.
Hi, Tracy Immel, Reimbursement and Policy Director with the Health Facilities Association of Maryland. HFAM represents 150 of the 230 skilled nursing and rehab centers in Maryland, and we're dominant providers of both Medicare and Medicaid services. We provide 4 million of the 5.6 million Medicaid days of care, over 1 million of the 1.6 million Medicare days of care, and nearly 6 million of the 9 million total annual skilled nursing and rehab days. There's 28,000 licensed beds across the state, but over 67,000 individuals are served annually because most of the people, about 2/3, are in a nursing center for a short stay, on average less than 30 days. And considering that this typically defines a Medicare patient, they're there for short stays following a hospitalization and are of a higher acuity because they're not well enough to go straight home. This really needs to be your target population, and this has been mentioned before, and so hopefully this will help me get through things faster because I don't have to repeat myself. You know, this is where there's a greater opportunity for savings. Looking at readmissions briefly, you know, nursing facilities like hospitals have everything to gain and nothing to lose by reducing readmissions. First of all, with lower readmission rates, you're more marketable as a higher quality provider. And every day that a patient is in your facility and doesn't go back to the hospital is the day you're actually getting paid for. So, you know, and this is important to hospitals and the state because you're lowering the cost to Maryland and Medicare. We've made great progress on reducing readmissions so far. Since 2011, the risk-adjusted rehospitalization rate has declined by 14.8%, saving Maryland millions. But to further this progress, we really need to look at and depend on effective and strategic partnerships between hospitals, skilled nursing and rehab centers, and their shared physician and nurse practitioner providers. So post-acute providers, they're not just another opportunity for savings. We really believe that they're the most important opportunity for savings. So offering a few policy insights and recommendations. Again, you know, we've heard the mention of interoperability of EHR. I think we need to look at the lack of funding that's been made available to nursing centers that's been available to physicians and hospitals, which might in part contribute to the low participation with CRIS. So whether that is state funding that becomes available to nursing centers or just creating easier pathways to the use of CRIS would have a positive impact on care coordination. Looking to find ways to share hospital physician specialists and nurse practitioner staff, creating more active and coordinated disease management programs, and possibly looking at removing the barrier that is the 3-day hospital stay. I mention this just because Massachusetts has requested a pilot from CMS to waive the 3-day hospital stay, but Maryland really should be ahead on this. We believe that they are the best state to test that model for 3 reasons. 1, our unique hospital waiver. 2, our strong hospital capacity, and also our strong nursing facility capacity. So I give you that broad context, and I'll leave it to Lou here to finish us off and get into some of the specifics.
Great, thank you.
Hello, my name is Lou Grumwell. I'm the CEO of Lorien Health Systems. This is the second work group of the commission I have appeared before. First one was hospital and nursing homes, how they can work together to reduce hospitalizations. My hat's off to all you commissioners to sit here for 3 or 4 hours and listen to everybody talk. I thought you would enjoy seeing some of the fruits of your labor. So sit back and take a look at the video, please.
I think
the road to recovery includes some setbacks.
there we go.
A new partnership with Lorien Health, University of Maryland, Upper Chesapeake Health, and LifeBot uses telehealth technology to help patients make a speedy recovery without an expensive trip to the hospital. As Lorien staff recognize changes in the patient's condition, they escort the patient here to a new exam room that features patient monitoring and video capabilities. The nurse connects the patient to LifeBot and enters baseline clinical data.
Conditions such as simple pneumonia, mild congestive heart failure, urinary tract infections, changing conditions as far as mental status goes, low blood sugar or hypoglycemia, or high blood sugar, hyperglycemia, would be conditions we could successfully treat.
Emergency physician expertise is just a video call away here at Upper Chesapeake Health. Providers manning the LifeBot system complete the connection and work closely with the Lorien team to assess the patient. Clinicians review critical patient data, such as EKGs and pulse oximetry, as well as lab and imaging information.
Lorien has been able to implement ISAT, so we have real-time laboratory testing available to us. We have radiology turnaround times within 4 hours, and we also have a medication drug box that is essentially matched with what we have in the emergency department with regards to antibiotics, IV fluids, and some basic resuscitative medications.
The emergency department physician can select one of 3 cameras mounted in the Lorien exam room, allowing for visual inspection of the patient.
When I started initiating my first call, I was able to do almost a mini neurologic examination to feel better that the patient wasn't suffering from any kind of neurologic deficit or focal neurologic deficit that would make me think of a stroke. Instead, I was able to assess and see that it returned to baseline because of the video capability.
Once all the necessary information has been processed, a clinical decision is rendered. A new care plan may be started at Lorien, or the patient can be transferred to Upper Chesapeake for further evaluation.
So what is the benefit of preventing an emergency department transfer from the nursing home to the emergency department? These patients are normally elderly. They may be frail, multiple medications. Being removed from their normal environment can cause them to undergo sundowning or worsen dementia. They can be at risk for falls, other infections. There's risk towards being in the hospital. So there's a lot of good that can come from caring for the patient, maintaining high quality care, and keeping them in their normal surroundings at the nursing home.
Our patients at Lorien Bel Air have been very pleased with the telehealth encounters. They've been able to talk with a physician at the hospital, and it gives them confidence in the treatment.
That's a result of your waiver, the author of the waiver, and the waiver pushes your work is working. Hospitals and nursing. We've been in Harford County for 23 years. Haven't had hospital physicians in our building for 22 of those 23 years. All of a sudden, I have many Upper Chesapeake physicians in our facilities, which is the good news. It's what the waiver was intended to do.
Great. Thank you so much. Excellent video. Thanks to all of you for very good presentations. And you can be sure that we won't forget about post-acute care. And we do intend to encompass and include it in the report, but we've learned a lot from this session. Thank you. So our next session is faith-based initiative. I thought I saw Vinny in the back and his colleague, Suzanne, I believe. Welcome.
Thank you so much. Thank you, everybody, for having us. I'm Vinny DeMarco, the President of Healthcare for All Coalition. With me is Suzanne Schlattman, Deputy Director. Thank you for this opportunity. I want to start by thanking Donna so much for being so open to consumer involvement, for appointing Lenny Preston and myself to task force to work on getting the consumers involved in this whole process, and we thank you very, very much. And I want to thank Carmela for working with me on my task force, and with her help, we've had 2 meetings last June and this January at MHA that have been very good and very well attended, the NAACP, AARP, faith leaders, and many other groups involved. We've begun a process of holding forums across the state. And at these forums, we talk about health system transformation and talk about the faith network that I'm going to talk about in a second. I think we should have pictures. We have anyway, I was hoping you had a slide of we have some pictures from we had 3 forums so far, and the first one was in Howard County. I want to thank Steve Snellgrove and Dr. Maura Rossman for hosting that one. They did a great job of bringing us together. John Calmers talked from the commission standpoint, and then we had local leaders speaking. We had one in Prince George's County that was also a big success, and Steve Forts represented you all very, very well. It was hosted by Collective Empowerment Local Faith Group. We had president of Southern Maryland Hospital there. And yesterday we had another terrific one. There were 130 people at each of those. And yesterday we had about 60 people in Northern Maryland, and Donna did just an excellent job there. We had the local health officer and local hospitals represented. And they were terrific events. We're going to have about 10 of them across the state. And you can find out all about this at healthcareforall.com. And there's where all the forums are happening. At each of these forums, Suzanne, along with an important local faith leader, Reverend Irance Reddix, talk about this faith network, which I appreciate the opportunity to talk with you about. It was at the meeting that Carmela hosted last year where Reverend Reddix encouraged us to go to Memphis and see what they were doing there. So a group of us, including some top faith leaders, and Mark Luckner from the Community Health Resources Commission was there, as well as Fran Phillips and Patrick Dooley from the University of Maryland, and many other faith leaders. And we went to Memphis, and we heard an all-day presentation that really, really impressed us. And as a result of that, Suzanne put together this document, which you should all have, which describes what's going on in Memphis and how we believe it could be adapted here in Maryland. So I'd like to run through you what they do in Memphis that works so well and how we are hoping to adapt that in Maryland. About 10 years ago, or 2007, they decided that they really wanted to help get the hospital more engaged with the local community and improve population health and healthcare in a community. And some local faith leaders came to them and said, we have a way that we can work together. And together they developed what they call the Congregational Health Network. And in your packet is a chart on which hopefully will be up there, but if it's not, if you look on page 3 of your packet, you'll see a model of what the Congregational Health Network is. So I'm going to run through what they do there, and again, how we believe we can adapt it here in Maryland. In Memphis, what happens is that the hospital enters into something they call a covenant with, and this is Methodist Hospital in Memphis, which is about 40% of the market there. And I guess we have more. You don't have all of these. Okay. Whoever doesn't, I'm sorry. I thought you did. Page 3 is this chart. That has what I'm talking about. But the hospital, through this covenant with the congregations hires navigators. And the job of these navigators is to coordinate work between the hospital and the faith community. And if you look at the appendix, right after the end of the conclusions, you'll see that covenant. You'll see the actual language of the covenant between the hospital and now, they said, 600 local congregations. The hospital hires a navigator, and these are hired people that work for the hospital. The hospital spends, they say, about $600,000 a year on salaries for these navigators and on training for the faith leaders. The faith leaders, in their turn, identify what they call a liaison, someone who in the congregation will be particularly working with the hospital to help their congregation. So there's a liaison who's volunteer, sometimes a faith community health nurse, but often not a layperson. But there's someone who's used to working with, they're helping the people in their congregations. So the liaison and the navigators are the two key people here. Then they have a document, which you also see in the appendix, a registration form, where the congregation, members of the congregations are asked to decide to be part of a congregational health network. And if they sign this document, then they're part of the network. And as you see, there's HIPAA language in there saying that the person agrees that the hospital and the liaison can communicate about their health issues. So the person signs this. When a person from the congregation goes to the hospital, the intake person at the hospital has, of course, the database. One of the required fields is the person a member of a congregational health network? It's a required field that the intake person has to enter. And the hospital even goes beyond that and knocks on doors to see, are you a member of the congregational health network, if people didn't sign up that they were. When someone is identified as a member of the congregational health network, one of the navigators is alerted. And the navigator then talks to that person and then communicates with the liaison. Again, the person is asked, are you okay with us communicating about this particular hospital issue with the congregation? If they say yes, then that communication continues. And while the person is in the hospital, the navigator and the liaison talk with each other about what the person needs. The person may need a visit from their pastor right now. Could you arrange that? They may need their family to come. So the navigator has someone to talk to, and the liaison has someone to talk to. What's going on with our person? Our family wants to know, and so there's someone that they're communicating. And that happens while the person is in the hospital. When the person leaves the hospital and goes home, the navigator tells the liaison person, John is coming home. Here is what our doctors say he or she, they need. These pills, they need this, they need that. He also tells me he needs his lawn mowed. He would like some maybe spiritual help. These are what he says he needs. And there's in the document a congregational care plan that the liaison and the navigator work out on what the person needs once he or she is back in the community. A lot of that's medical, but a lot of it is not medical. A lot of it is what you've heard talked about before, things they need in their home. Maybe they need heating. Maybe they need, like I said, their lawn mowed. Whatever it is they need, it's in the congregation health plan. And before that, you'll see a description of navigator responsibilities and liaison guide for each of them, so they know what they're doing. And in that process, they help to coordinate care. And they help to go beyond that and coordinate needs that the person has after their hospitalization. And the results are, we believe, dramatic. If you look on page 4 of this document that Suzanne put together, you'll see some of the charts on results. The hospital, as I said, spends about $600,000 a year for the navigator salaries, for training, and they use their community benefits money, by the way. They don't have the waiver and everything we have here. That's what they use their community benefits money for. They believe they save $4 million a year in reduced readmissions, less stay in the hospital, et cetera. Now, there might be different, money may mean something different in Maryland because of our all-payer system, but they do save lots of money. And more importantly, from our perspective as consumers, look at the results in decreased illnesses, decreased morbidity, decreased time stayed in the hospital. It's really dramatic. The hospital took very good care to test this, to evaluate it. And over these years, they've compared this congregational health cohort with other people in the hospital, including other people in the hospital who say they're very religious but aren't part of a congregational health network. And with all those other comparisons, there's a dramatic improvement in morbidity and mortality and reduced per person health care costs because you're in the congregational health network. As of today, the Memphis hospital is working with about 600 faith congregations. They had wanted to do, 400, but more, they can't do any more. And about 20,000 actual congregants have signed these congregational health network documents. But really, their reach is much broader than that, because many people aren't going to sign something like this unless they have to go in the hospital. So they really have a much broader reach. And in addition, the congregations that are part of this network help people in the community who are not part of their congregation. The hospital identifies people who go to the hospital a lot. They call them familiar faces. And they say to the congregation, there's a person near you, they're not part of your congregation, but they come to the hospital a lot. Can you provide some help? And there's someone from the hospital who works with the congregation, and that has helped to reduce visits to the emergency room, et cetera. So it's a very successful model. We believe it can be adapted to Maryland. I want to thank Carmela for inviting Reverend Bobby Baker from Tennessee, who gave us this presentation, is going to come next week to Carmela's population health meeting to talk to hospital leaders from across the state about what they do there. We believe this can work in Maryland, and we talk about it at each of these forums, and I tell you the response is overwhelmingly positive. Yes, we want to do this. And I can tell you the faith community of Maryland is ready and eager. One of the top leaders of the United Methodist Church was with us in Nashville, and she came back saying, we got to do this. She said that her bishop is willing to get engaged, to encourage all 500 United Methodist churches in Maryland to become involved. I'm scheduled to make a presentation at the Ecumenical Leaders Group in a couple weeks, which is all the top Christian leaders in Maryland about this. I've talked with the Baltimore Jewish Council who are very interested. When hospitals want to do this, the faith community of Maryland is ready to engage. At the moment, Steve Snellgrove at Howard County General Hospital is very interested in this. Snellgrove came from a community in North Carolina that was implementing a similar program in Wake Forest. He's very interested. He's seriously considering applying for one of the BRFA grants to do this there. And a group of faith leaders is meeting in a couple of weeks in Howard County to talk about how they would work with them. In Prince George's County, the Collective Empowerment Group, which is the main faith group in Prince George's County, is big time into this. Their director, Reverend Diane Johnson, came with us to Memphis and is ready to go, and the hospitals there are interested also. I could tell you yesterday in Carroll County, we had Carroll County and Frederick County leaders there. They are into it. I've gotten several emails from faith leaders in Carroll County and hospital folks in Carroll County saying, let's get together and talk about this. And Suzanne and I have a meeting in a couple weeks with Dr. Sam Ross, the head of Bon Secours, talk about this, this possibly there. What we want to have happen is several pilots in different parts of the state to happen right away to see how this would work in different communities in Maryland. We'd love it to happen in Howard County, in Baltimore City, and maybe in more rural areas also, so that other hospitals can see how it works. So we believe this is an exciting way to achieve goals. Let me close with this, and maybe Suzanne wants to add something. Congregations always do things like this. They always have people who try to help their congregants who are sick, who will go to the hospital. What's unique about Memphis is that person in that congregation has a direct line to someone in the hospital, and they're talking back and forth. So they love it. And Memphis Hospital loves it because it has dramatically positive results both in quality of care and in cost.
Great. Thank you so much, Vinny. It's very exciting. Suzanne, did you want? We only have a couple minutes, but if you want to add a couple words.
He pretty much said it all. One thing I would want to add, just to tie it all into what we've talked about already today, is that this is a great example of how a rather low-tech community care plan can have such a great impact. If they're already comparing it to people who don't have this one piece of paper community care plan to people who do, and seeing incredible results. So I'm very excited about the conversations you've had today, and any way that we can support you and the launch of a Faith Community Health Network here in Maryland, I think is perfectly in line with that. Please stay in touch.
Thank you. We will, I'm sure. I appreciate not only your presentation, but as always, the energy that you, and excitement, enthusiasm you bring to it. It's well received. Thank you both very much. Our final panel is on hospital collaborations with community-based initiative and involvement in community-based initiatives. And we have two guests from Howard County.
Hello, good afternoon. It is hard to be last and hard to follow Vinny, but we appreciate him coming to Howard County recently, and we definitely had a good turnout. I'm Maura Rossman. I'm the health officer for Howard County Health Department, and I'm here with Mr. Steve Snellgrove, the CEO of Howard County General, to talk about our Howard County Community Care Team initiative that is about in about 1.5 years into its evolution, call it like that. Our community, I could be able to read that with my old eyes. Our community, we call it our Community Care Team, is part of our larger Community Integrated Medical Home project. And this is a collaboration with the Health Department, Horizon Foundation, a health philanthropy group in Howard County General, and also working with Healthy Howard, who is a 501c3 nonprofit organization in Howard County. This project utilizes population health strategies to decrease preventable hospitalization among the highest utilizers and uses hotspotting, data collection, and analysis. Its genesis came about the time when the state was building out the state innovation model, and I had the opportunity to participate on the payer group, which I have to admit was not my comfort level in being with the payer mix, but like most things where you don't know very much, your learning curve goes way up. So again, I have to thank, I guess it was Laura who allowed me to participate, put me on that group. The three essential components of this community care team and integrated medical home is the strategic use of data to identify the population with whom we should be working, and continued use of data, metrics, and data analysis to ensure that we're on the right track and having the outcomes that we desire. The community care team is comprised of licensed and non-licensed professionals, community health workers, as well as registered nurses and a program coordinator who engage eligible clients at the bedside during a hospitalization and work with them over a 90-day period in their home. In addition, we are working with primary care practices in Howard County, because certainly there needs to be a warm handoff in the transition of care between the hospital and the folks who are working with them, the primary care providers, to keep them out of the hospital. We're not going to talk about that transformation practice model today. So in, I guess it was 2013, when we started to analyze the data, we used 2012 data from Howard County General Hospital. Dr. Jeff Brenner from the Camden Coalition helped us analyze this data using his hotspotting analysis techniques. And as you can see in this graph,
he's the guy that takes it down right to the building, right, sometimes?
Yes, he does, absolutely.
Yeah, I've read some of his stuff. Thank you.
Yeah, which we can talk about that another time as well, because it was surprising and really not so surprising where our high utilizers in Howard County actually reside. But as you can see that, you know, I think it was mentioned earlier that there are relatively few clients or patients who consume very large amounts of our healthcare dollars. So the total charges of our extreme high utilizers, you can see, is $4.5 million of 61 patients. And then our high utilizers, 322 patients at a cost of over $15 million. And we said, aha, we should be able to work with our high utilizers and super high utilizers, focusing on the social determinants of health, which I think has been talked about a lot today, in helping keep them out of the hospital. We recognized that we needed to have some return on investment here, and as you can see, you know, I think I just explained the numbers of where if we focused on certainly the yellow and the red zone with a cost-effective staffing model, that we should be able to show some return on investment. The goal year one really was a proof of concept to see if we could pull together a team in Howard County and engage patients and have them follow us through 90 days and keep them out of the hospital. Again, we were focusing on high utilizers and delivering cost-effective community interventions. Again, we modeled this, as I said, on Camden Coalition, but also on the Coburn model that's in the literature. And obvious reasons that, as previously stated, that our high utilizers represent a disproportionate amount of our healthcare dollars. And we reasoned that if we connected patients with their primary care providers, they would receive better coordinated care. And certainly we focused, listening in the back, focused a lot on care plans and coordination of care. And closing the communication gap between hospitals and the outpatient providers to provide less fragmented care is absolutely critical. And our team members also talk about trust and relationship building, which is essential. Again, we currently have 4 community health workers and 2 registered nurses who provide hands-on, they engage the patients in the hospital, enroll them in the hospital, and then follow them as outpatients, making home visits and as well as telephone visits. They connect the clients with their primary care providers. If they do not have insurance or they do not have a primary care provider, they will work with the client to establish both insurance and a primary care provider. The goal ultimately is to empower the patients to actually make these decisions and connections on their own at the end of the 90-day period. So it is not to continue this, but to create a learning environment where they feel comfortable and enabled to make these decisions on their own. Initially, when the community health worker and nurse go into the home, the first thing they work on is med reconciliation, which I think all of us in the room know. For a hospitalized patient who has been pretty sick, med reconciliation is really key on the list in terms of helping them follow their care plan. They also provide chronic disease management, which can include dietary suggestions, physical activity, etc. They help coordinate transportation to and from appointments as needed. Not all, most of our clients are elderly. The mean age is 65. They may not be able to drive themselves. One of their family members may be working and not be able to drive themselves. So again, connect them to the rich resources that we are fortunate to have in Howard County. They will also connect them with other social services. We have really beautiful senior activity centers, so socialization I think is very important in helping keep folks out of the hospital, and they'll help connect with our senior programs and again or other community service, which can include obviously the faith-based community as well. And I think of most importance, again, I talked about empowering, but really facilitating the client to manage their own health condition. And our team really focuses on meeting the patient where they are at the current time to help move them forward to what their goals are. So if their goal is perhaps to be able to go see their grandchild's play at school, then that's what they will focus on rather than perhaps a loftier goal that
a physician may really want them to aspire to have, like being able, to run a mile or something like that. So meeting the patients where they are is really critical, and they use a lot of motivational interviewing techniques to do that. Steve is going to talk about the role of Howard County General in this.
Really, the role of the hospital is relatively simple, to follow the process that had been established under the grant. And that's what you see up there on the slide. Really, we were to provide the admission and discharge data to the community care team coordinators and generate daily reports from our EMR. Our case managers were then to screen the patients, make sure the ones who are eligible got sent on to the community care team. And if you flip to the next slide, you'll see that in theory, that's how it should work, but in practice, we run into barriers at times. And you can see very visually from the graph that it took us a number of months to kind of get our act together. And it's cultural issues. It's the ability of a hospital to work with people who don't traditionally play in the same sandbox with you, yet need to under this concept of population health. And our case managers, when we first got this grant, were really supposed to, on the day of discharge, begin to screen the patients and make the handoff to the community care teams. That didn't happen very well because they weren't always seeing the patients on the day of admission. So we ended up assigning one of our young fellows to the project, working with Dr. Rothman, and he quickly discerned what was going on, and daily now he creates a list that is sent to the case managers. They check on eligibility, and as you can see from the graph there, the number of people who are referred has gone up significantly, and the number of enrolled has gone up significantly as well, but not quite to the level that we would like to see.
I want to point out that, again, from hearing earlier, our referral to enrollment is about 55%. So about 55% of folks will decline our free intervention, and I think you were talking about that with care plans. Why would somebody refuse? We delved into the data a little. Our N is relatively small, so I can't say it's statistically significant, although it appears to be. Of those clients with medical assistance, there is a 100% enrollment. Folks with private insurance and Medicare, it is a 60% declining enrollment. So we're trying to further figure out what makes someone enroll and what makes someone not want to enroll.
So you can see this is the outcomes that we've had to date. The N is 83. And the clients with a care plan created in the first home visit, it's 94% out of our goal of 100. Clients with initial primary care physician visit within 7 days of discharge is 39%, above the goal of 30%. Clients with initial home visit within 3 days post-discharge is 45%, compared to 60. And clients successfully graduating is 82%. So we've made some good progress there. The average days till graduation is 80, in comparison to the goal of 90. We'll flip the slide. Now this is the real slide that's important. It's relatively hard to read. But what we did here is we looked at patients who were receiving care 60 days before the intervention and patients who received this community care team work after the intervention. And the critical issues are the number of inpatient admissions pre-enrollment was 33. Post-enrollment went down to 18. This is where the numbers are statistically significant. The number of inpatient hospital days went from 259 to 183. The average length of stay actually didn't change that much. It went from 7.9 to 7.4. On the observation unit, the number of observation stays went from 7 to 4. The number of days went from 16 to 12, and the average length of stay actually went up slightly. Now, the emergency room visits is also very important here. The number of ED visits went from 18 to 9 for this population, and the number of hospital encounters went from 58 to 31. So you can see that we were really making some progress in that space. Now, a couple of our lessons learned is that relationships are everything here. We really have to get together and not just communicate through emails about what the process is. We really have to find process owners at each component of the continuum that we hold accountable, measure the results, and then go back and tweak the things that aren't working. And I think what we've seen here was a good example. We ran into some challenges navigating our EMR Epic to get this data, to cleanse it, to make sure that we're sending the right information along, but we've moved ahead on that. The good thing is this evaluation was built in at the outset, so we knew that we would have to go back and assess our progress. and we demonstrated a good partnership. Maura has become my partner in Howard County towards population health management. We recognize the pool is vast, but I have her on our strategic planning committee at the hospital. She's even interviewing some of my population health and strategic planning staff. We think that highly of this new relationship together. And so a couple of things that we've got to continue to work on is approximately 55% of the eligible patients who are not using it. We have to do more discovery, but we think that this was a great success. Flip the slide here, talk about a couple of things that we've done in really conjunction with that for continuous improvement. We have on one of our floors, 4 South, a pilot with a new director of social work. We actually took case management and utilization review and social work and split it back into kind of the traditional process of social work, because it's so important today to look at the social determinants of health while the patient's an inpatient and to make sure we have the right handoffs back in the community. That kind of got lost in the last couple of decades of acute care, and we see that value proposition coming back to the table. The other thing we've instituted, and it's not unique to Howard County, many of you as hospitals have probably done this, but multidisciplinary rounds where our hospitalists are working with all the care providers every day, 10 o'clock in the morning in our units, and we've seen significant reductions in length of stay and significant improvement in our discharge plan and patient satisfaction associated with that.
And lastly, we recognize the need for continuous quality improvement, and one of the things we have just recently began piloting is a web-based application tool called Care at Hand, developed by Dr. Andrea Stresky. And we hope that this tool may allow our team to become even more efficient. It creates algorithms and allows the community health workers, by asking very brief, simple questions, to risk stratify the patients in terms of their health care needs when they go and see them. And this was borne out because we're dealing with very sick people. You can imagine the super utilizers. These are very complex needs that sort of went beyond the scope maybe of the social determinants in keeping them out. So we're exploring that at this time as well.
I'd just like to, final word on the previous subject with Vinny and Suzanne. I've led a faith health initiative in North Carolina. The architect of the Memphis model is a fellow named Dr. Gary Gunderson, who actually joined us at Wake Forest Baptist Health a couple of years ago. So I got the opportunity to work with Gary. He's from Pikesville, ironically. And he was instrumental in getting that going on in a not-for-profit in North Carolina called Faith Health NC. And just like it's reverberating through Maryland, it has really taken hold in North Carolina. What worked in Memphis, what worked in Winston-Salem will be different than what works in Howard County. But the principles are the same, and this really complements many of the presentations that you've heard. Well, thank you. I mean, your slides, which we will study more carefully with your permission, really show that proper targeting of very high needs patients who are accounting for just an astonishing amount of use, similar to what Dr. Carter was talking about earlier, of a small number of people, 20 admissions, I think you said, in a few months. It's really dramatic and good to see that the early results are so encouraging. So thank you. Ben, did you have a question?
Did you have any opportunity to do any cost analysis on 65% decline? Why they do that?
Not yet. We just got that data actually about 10 days ago, or maybe not even 10 days ago. So we're beginning to look at that.
Okay. This is a point. Most of the people that I'm facing are the panelists, but there are a few that are here from the public. We only have a couple minutes left. We do have to wrap up. But if there's anyone who has been kind enough to sit here all day and has a quick question or comment, you may ask it now. Yes, sir. Just introduce yourself, please.
Sure. I'm Paul Arias, Corporate Director for LifeBridge Health Care Management. Sure. Paul Arias, I'm the Corporate Director for Care Management for LifeBridge Health. We talked a lot about today care planning, data integrity, and data management, risk stratification, and segmentation, and moving people into identified physicians and identified groups. How are you going to reconcile that with the people who are doing ACOs? Because they're doing the same thing already with a subset of population. So there is something that needs to occur there, because what's in number 3 on section 2 really says that this is what you're going to do for the patients that are really being done for the ACOs. So there's got to be some kind of reconciliation, I think, when you do something like that. And there's some lessons to learn from the ACO model.
Yes, and we are looking at ACOs. We have a whole group working on that, but you're right. We can't pretend that they're totally unrelated. Thank you for that comment. I think I saw one more person. Oh, 2, I'm sorry. Yes. Oh, Lenny. Hi.
Hi, I'm Lenny Preston. I'd be remiss if I didn't introduce myself as the chair of the Consumer Engagement Task Force. Our thanks to HSCRC. So much of what you talked about today is one component of what this task force will be looking at, more on the patient engagement side, and we're looking at the much larger consumer engagement side. So we've been tracking what you all are doing, and we're looking forward to integrating what your conversation is with our larger conversation, and looking at audiences, messages, the messenger, which will be different for many, and looking at very targeted calls to action and leveraging the right time to get those messages out there. So I appreciate the conversation today and looking forward to whatever more you come up with.
Thank you, Lenny. And there's a gentleman that has the last comment, please, and thank you for your patience. Come on up.
So my name is Faribur Zarfashan. I'm a practicing pharmacist and part of that public. So I've learned a lot attending these meetings for the last several times. I was taking a lot of listening to a lot of comments here, and I realize I'm preaching to the choir here. But I know we have one more meeting, so I wanted to get my point out. Engagement of the public, engagement of the patient, something we talked about a lot here. I would say the common denominator in my 28 years of practice across different settings, from acute care to long-term to home infusion to all of that, is that the medication management issues have been and continue to be a significant reason for hospital admissions and readmissions, and we know that. So we look at the data a lot, so we want to engage the patients, and we know the importance of engaging, but the way we look at it is we need to engage the patients to really prevent harm. That's our ultimate goal. And that prevention of harm, ultimately, where we want to go with that is to improve the population health at the community level. You know, we talked last time here, somebody brought it up, I think it was Dr. Carter that brought it up, that, you know, within the acute care setting, it's such an organized setting. And we have so many resources, and that's wonderful. We can do all kinds of handoffs. But once the patients go out in the community, that's where they come back from. And what can we do at that level? Now, a lot of the medication-related issues that happen are post the data point. And what I mean by that is, what are some of these things that cause people to come back? It's access issues, potentially complexity of care. It's drug interactions. It's what we don't know that's going on. It's patients' lack of understanding, forgetting how to take meds, whole host of stuff, underdosing, overdosing. A lot of that stuff is post the dispensing and the fulfillment point. So when we look at pharmacy data on the aggregate, on the 30,000-foot view, we get ourselves to the point of dispensing, and okay, now we know the patient potentially got the med. What really happens after that is the key factor. So we're taking a bunch of initiatives, and I'm not here to talk about, advertise about what we do, but there's a lot of innovative ways not only to deal pretty low-cost ways to some, and some may not even be low-cost but necessary. As a practicing pharmacist, I can tell you that pharmacists are not being enabled or tapped to do what they can be doing. You know, as long as we keep looking at this profession as a poor lick and stick, or really the corner drugstore dispensing and fulfillment type function, I think we're missing an opportunity here. And medication therapy management, as many of us know, and I'll just say that to reiterate for those of us who may not know it well enough, medication therapy management that was part of the Medicare Modernization Act is really more than just reviewing brown bagging the patients. It's looking at the patient's conditions, looking at the clinical guidelines, looking at really using the trust that the patients have with the pharmacist to figure out what's really going on. We know PBM data is not going to tell us about the OTC meds. We know it's not going to tell us about the herbal meds. And I tell you what, the patients don't even disclose that stuff to the providers because they don't want to disrespect them. So MTM is able to not only capture that information, but work in a triad with the providers to prevent that harm, to prevent that hospitalization. So I'm just inviting us to consider as part of our recommendation. I know we want to be 30,000-foot view, but this is a specific that's worth thinking about, to think about how we can enable pharmacists, or at least tap into the profession and be able to get us there, because what I just talked about, the medication-related issues are fixable issues. And like Rob said, who's not here now, but he said we want to go in the right trend. We're not going to fix all these problems. But if we can put a dent in it and do a 60% improvement, many of the categories I just told you are fixable, and not with a whole lot of expense. So thank you.
Thank you. And by the way, Fairvoice, thank you for your email, in-depth email, which I have shared with a few of my colleagues. So we will try to capture your advice. Thank you all. The final meeting is February 27th at 9 a.m. Well, I'm hopeful. But I turn it back to you for final thoughts.
Jack, thank you very much. Thank you to this work group. We will get back to you with a revised chart, see if we can do some work between now and the proposed final meeting, and see if we can expedite a set of recommendations. Jack, thank you very much for guiding us today. And thanks to everybody who stayed to offer their thoughts. We appreciate it.